30 seconds to go live.
Okay.
We are going live in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Hello, good morning, good afternoon, and good evening. I am Shahid Noor. I am the president of Asia Pacific Hip Society, which is a section of Asia Pacific Orthopaedic Association. With me is Professor Abhay, Elhence, who is the Secretary General of Asia Pacific Hip Society. I welcome august and top faculty from across the globe. They come from United Kingdom, Australia, Japan, Turkey, India, Pakistan, and Saudi Arabia. I also welcome the participant of this APHS 360-degree webinar series. The previous webinars have been extremely popular with more than 2,000 viewers. There has been very interactive session, and we have a very positive feedback from the participant. Today's webinar is on total hip arthroplasty and dysplastic hip. We have covered different aspects from planning, diagnosis, classification, management, and complication. Also, at the end, we will have a new classification for type 4 Crow type dysplasia. So I encourage all participants to actively participate and ask questions. Your question will be answered by top faculty. Also, through the platform of Asia Pacific Hip Society, in future, we plan to conduct various workshops, hands-on cadaveric workshop on primary and revision hip arthroplasty. We also plan to conduct fellowship on primary and revision hip arthroplasty, and also visitation of the faculty. In this regard, faculty who are present here and other faculty who can contribute in fellowship or workshop, cadaveric workshop, please coordinate with us. Without wasting a single minute, I would be handing over the mic to my colleague, Abhay Elhence, who would be introducing each faculty, and we would go live. So enjoy the webinar.
Thank you so much, Shahid, sir. And a very warm welcome to all faculty. Thank you for sparing your time. We have a galaxy of star dysplastic hip surgeons. This particular webinar is one with a difference, because we are not only touching the borderlines of joint preservation to joint replacement, but we're also talking of different and new understanding with a new classification. So while we are going to talk principles and techniques and approaches, we are also going to be talking complications and new understanding in the form of new classification. So very grateful to all of you for being present here. And without wasting too much time, may I request Dr. Tahir to please start his presentation on hip dysplasia from preservation to replacement. Thank you so much, sir.
Thank you very much, Abhay. Thank you, Shahid. And a very warm welcome from sunny London, 23 degrees today. So my task is to introduce you to hip dysplasia, if I may. So we've all seen this kind of X-ray whereby the hip is quite arthritic and has a lot of telltale signs from previous surgery. And I'm sure we've all seen a very good hip replacement performed on them. But no apologies to say that a lot of these patients start their journey in an X-ray like this one, where the hip presented with a dysplasia and dislocation. And it was treated as well, and arguably not very well. These are the cases which end up needing a very complex hip replacement, and we'll come to that through the session today. So what is hip dysplasia? We all define it in a slightly different way. At birth, it's instability, subluxation, dislocation, clicky joints, and all sorts of names have been given to it. Sorry, I think I'm not in a presentation mode. Okay, yeah. and they can have a positive ortho and bodily maneuvers. At 1 year, there might be a delayed walking, and later on, they can have a combination of symptoms and signs, including limb pain and deformity. And some would say that quarter of all hip replacement have some form of dysplasia as the underlying cause. By natural history, about 1 in 4,000 live births, which means there are 385 children born in the world every day. And hence the caseload is increasing literally by the day. We also know that the babies which are born with a dislocated hip, with or without treatment, a quarter of them would have a normal hip at 5 months. And the ones with subluxation, half of them would have a radiologically normal hip at about 5 months of age. So if they're treated early, they do really, really well. If they're not treated, or they have a persistent dysplasia, even with treatment, or a residual dysplasia, that is the one which will be the topic for discussion today. My mentor, Alan Gross, published in 2012, and he said the commonest cause of arthroplasty in 40-year-old females is actually hip dysplasia in one shape and form. So no apologies to share this dissection by Ignacio Ponsati, who wrote a book on hip dysplasia based on his series of 3 cases, which were stillborn children with dysplastic hips. So the problem is literally not only in the acetabulum, which is very obvious, the acetabulum is oval. The femoral head is displaced as well with flattening, even at birth, and the triradiate cartilage is abnormal as well. So his thesis was that it's not possible to create a normal hip with a dysplastic joint. That obviously has been challenged by others and has been proven that we can have a near normal hip with a successful treatment. And again, no apologies to share a child from a pediatric literature, the blocks to reduction. And I would stress that these blocks to reduction, although seen in children, they persist through the life. So patients coming in for treatment later in life, they still have soft tissue contractures. The labrum is still a problem. Ligamentum teres can be an issue. And the structures in the fovea centralis can be a problem to manage. And they usually later on, and you guys know more than I do, would have a massive central osteophyte. Tony Cattrall would say the outcome is literally in one of 4 categories. They either have a normal acetabular development or they have a poor acetabular development. There's also a case of long leg dysplasia. If you do treat these hip dysplastic patients, you must monitor their leg lengths. And if they have long legs, then you need to treat them. If you don't, they will end up having persistent dysplasia because of that. And we due to write a paper on that these patients who come in for hip replacement later in life, they end up having leg length inequality because surgeons not always realize that the leg being treated is already longer and that has to be equalized. There can be malrotation of the acetabulum, and hence it was suggested that these patients should have a test of stability, and that will tell you what sort of treatment would they require. In pediatric population, the decision-making is relatively easy. You can do one of the pelvic osteotomies, and they usually have a decent outcome because they have a lot of remodeling potential. In a skeletally mature patient, though, remodeling potential is debatable or non-existent. Their anatomy may be altered because of previous treatments, previous remodeling, and avascular necrosis, which, according to Bob Salter, is the risk is 100%. You can either have a minimal avascular necrosis or a very deformed femoral head, which we are all aware of. And in these cases, the options are either to consider preserve the hip, which would be my preferred choice, go for a symptomatic treatment and get them ready until they need a total hip replacement, or consider hip replacement in young people. And again, there's a lot of publication with good outcomes, including one of our own, but we will all agree that hip replacement in somebody who is 15, 20 years of age is not always as easy and as pleasant an experience as somebody who's 60 or 70. And hence we go for the hip dysplasia treatment to preserve the hip. And this is one patient who was treated without pelvic osteotomy as a child. And we know there's a persistent dysplasia. Hence, we ended up doing a Gans type of periacetabular osteotomy. We actually overcorrected it a bit, but she's asymptomatic. And if she does need further treatment, we can preserve the hiplet by doing a pincer resection. So what is hip preservation? So we want to preserve and enhance the hip anatomy. And by that, I mean bony anatomy, articular cartilage health, labral cartilage health, and hip girdle muscles. And it's important to consider all four of them. And if you can't correct all those, then preservation may not be as successful as you wanted it to be. And we also want to preserve function and possibly improve function. And the most important bit is to delay the need of arthroplasty. It is not to eliminate the need for arthroplasty, which remains on the cards. You need to work it out. You need to understand the deficiencies and in 3 dimensions if you want to do hip preservation. You also want to know the labral cartilage and the hyaline cartilage using the DGEM rakes and the 3 Tesla MR scans. And based on those investigations, you can decide what to do. So this 16-year-old football academy player was diagnosed with a labral tear when the underlying problem was actually hip dysplasia. So we were able to do a Salter type osteotomy and repair the labrum, and he has been playing at a professional level for the last 6 years. Whereas this other patient, as you can see, is more complex. She presented with a labral tear as well, but she has false acetabulum as you can see. The Shanton's lines are broken, and there's already some form of subchondral sclerosis. So we decided to do this after investigating it properly with arthrogram and MR scans. And she's again about 7 years down the line, still remains asymptomatic. And I would suggest that maybe some of the subchondral sclerosis has started to resolve because it shifted her weight bearing. We were able to restore the Shanton's lines, but there's still a gap medially, which worries me, but her symptoms remain good. So periacetabular osteotomy is a complex undertaking where you divide the ilium, the pubis, and the ischium and rotate it in 3 planes. Try to recreate normal anatomy with associated risk, benefits, and complications. And the outcome is generally good. At 10 years, about 80 to 95% of the patients remains asymptomatic. The outcome at 20 years is not as good, whereby 50 to 72% of the patients would be still surviving, and the others would require further treatment. Another option, which is becoming more popular, and although the evidence is actually against it, is try to repair the labrum, get rid of the symptoms, and that works reasonably well. In the short to medium term, I would say, for probably 3 to 5 years, they can be asymptomatic or symptomatically improved, but usually thereafter, the labrum tears again because the underlying pathology is still there. I would suggest to you that labral resection or debridement is not a great option in patients with hip dysplasia. You will actually increase their instability, and their symptoms do not necessarily improve, although it's quite fashionable in mainland Europe. I think it's not a great option. But if the labrum is as it is in this case, then there's no way to salvage it. And the only option then is labral grafting. There was actually a systematic review 2016, which came to the conclusion that it is a viable option, but the outcome is not as good as we suggested. We've looked at it and published recently that a patient of dysplasia who ends up with an end-stage arthritis literally passes through these 5 phases, and the top 3 are the ones where you can do things. So if there's a chondrolabral failure, that's when you end up in a gray area. Can you preserve the hip then or not? But before that, you should be able to do either a osteotomy or labral repair and expect to have decent outcome. And I put this slide in just for the comparison. For all the pediatric hip conditions, hip dysplasia actually has the worst outcome in the long term. So 2/3 of the dysplastic patients in 30 years will need hip replacement, whereas only 20% of Perthes and 50% of slipped upper femoral epiphysis patients would require total hip replacement in the long term. So hip dysplasia is unique because I think even the ones which anatomically look good, they are not generally as good as we think they are. So what are the options when you end up in the end-stage arthritis? And again, I quickly pass through them. You can do an orthodesis, and that remains a viable option, although very rarely. In the last 10 years, I think I've done 1. The reason being that all of these patients, 100% of these patients will have some issues. They're never happy until they had a hip replacement. You can do a Kelowna procedure, which I do sometimes, and this is 7 years down the line from 2015, and they do reasonably well. But half of them would be happy with the outcome, and the other half usually are not happy with the outcome because they still have some pain, they can't do sports and all that. Or you can do a girdle stone, which again I've done, I must say, once in the last 10, 15 years. And never really happy with the outcome. But, you know, if there's other, like in this patient, post-polio syndrome with dysplasia, we had to do that. And yeah, he's coping, but not really happy. So again, not the best option. And especially with an outcome like hip replacement, it's difficult to sell to the patients and convince the patients that there's alternatives to it. So that brings me to total hip replacement. And again, I'll leave it to you guys to talk it more. I've got a few cases to share with you. So this is one of my own, whereby it probably shows all the risks and challenges, which we'll talk through in the morning session. It's the patient expectation management, really, first of all. Then is the technical challenges. And then is the long-term outcome and revision surgery. So this patient, we lengthened by about 7 centimeters. Shedding nerve was fine, but the trochanter pulled off. You might say the acetabulum is not seated deeply enough, and there's a bit of an open acetabulum. She's okay with it so far, but I suspect she'll need an early revision earlier than expected otherwise. And when we talk about expectations, it's not just the quality of life, it's the sports and leisure, the peer pressure, and the family issues and the hobbies they want to pursue. And this paper, I think, is quite interesting because they looked at small number of cases and a medium-term outcome. And most of these patients that previous treatment, like periacetabular osteotomy, do not have as good an outcome after hip replacement. And the revision rate after 10 years or 8 years is higher, almost double than the normal hip replacements. And the same applies to the femoral osteotomies. They all have issues when they come for hip replacement. So it's important that you spend, and I know you're going to talk about a new classification, which I'm very keen to know about, but these are the ones which are available to us. I quite like Heterophylakides classification, but Crow classification remains viable. But why does it matter to know about it? Because this is not really a primary hip arthroplasty. These patients have had multiple procedures in the past. They have difficult exposure. There's femoral shaft perforations, implant malposition, all those issues. So I think these are the 5 cardinal things that you need to look at when you decide to do a hip replacement in a DDH patient. You need to look at the leg length, look at the hip center, have a low threshold for shortening femoral osteotomy, think of the implants, and consider primary stability. So this is where I let myself down again. And I forgot to realize that there is an intramedullary callus from the previous osteotomy, so that we lengthened her by 2 centimeters, which she wasn't very happy about, and the cup was a bit open, so we had to revise it literally within 2 years. So my suggestion to you is, I'm coming to the end of it, I would be very quick, is planning. And the planning can be 2-dimensional planning, which in my opinion is not sufficient. Or you consider do a 3-dimensional planning, which look at the acetabulum, femur, intramedullary callus, medullary canal diameter, foot position, and all those things. Gait analysis, and I do CAD/CAM planning a lot of the time. And there's evidence that that's very, very helpful. Low threshold for femoral osteotomies. And this paper from Sarah, all those at 80% 10-year follow-up, this was actually based on CAD/CAM 2-dimensional planning. And I'll share with you again some of the challenging cases. This patient was...
Dr. Tahir, sir, may I request you to please wind up, because we can do a lot of this in the discussion part as well.
Okay, I'll do that.
Yeah.
So we had to change the plan intraoperatively, whereas... I'll go to the last case, which I think is most pertinent. So this patient had ABN from previous treatment. We had to lengthen the leg and plan it so that we can shorten after lengthening. So we lengthened by 10 centimeters, shortened by 4 centimeters, and she's done well. So my conclusion really is beware of the pathology, have a bit of understanding of the previous treatment, plan and have a backup plan, and be aware of the complication. Thank you very much.
Thank you so much, sir. I know it's a huge topic to cover in the time allotted, but you've been brilliant. Two very quick questions on behalf of the audience questions that we've received. One is that at what stage of intervention are you likely to change the natural history of evolution of disease for these dysplastic hips if you were to do joint preservation? That's one. And the second one is there a particular type of pelvic osteotomy which you would like to do, which restores the hip to fair amount of normalcy, which will basically facilitate a total hip down the line? So two questions. One.
Yeah. So the evidence from literature and my own experience is that after 5 years of age, it's difficult to change the natural history. So the treatment before 5 years, and the evidence supports it from paper from Toronto and paper from UK as well with a 40-year follow-up, that if you do a rotational osteotomy, which is a Salter osteotomy, you can change the natural history, and the best outcome is with that. When you come in to do a salvage procedure, which could be a Chiari or a Gans osteotomy, you don't change the natural history, you just buy time.
Okay, may I quickly go on to one of the stalwarts? So Vijay, can I just ask you, if you were to do a salvage osteotomy versus early total hip, and I know you talk about total hip arthroplasty for the teenagers and the adolescents, so which one will you choose and why? Very quickly.
Yeah, we'll discuss more in detail if we have more time, but I think, arthroplasty has to be redefined now that we have got bearings that last for a very long time. And revision options are also very straightforward. We can actually plan for 3 revisions in a very straightforward manner. So these new things have started redefining our, threshold for doing arthroplasty in young patients. So I certainly would go for a total hip replacement.
So the basic call for you would be an early total hip arthroplasty versus a salvage osteotomy for these dysplastic hips.
I strongly second Dr. Bose, Vijay. Okay, I think what is available today is not what was available 15 or 20 years ago when those recommendations came up. I mean, at that time, doing a total hip in an adolescent or in someone who's an age of 20 and 30 was a nightmare. But at this point of time, that's not the issue anymore.
Yeah. So
we do total hips in sicklers, right, Vijay? We do total hips in sicklers, and their age is in general around 30 and 40s.
Yeah.
Thank you so much, sir. 20s. Thank you so much, sir, and thank you very much, Dr. Tahir, sir. We'll quickly move on to the next talk, which is a recorded talk because Dr. Jim has had to pull out at the last minute, and he will be talking to us on surgical principles, decision making, when and why. Dr. Jim, sir. Meenakshi, all over to you.
We cannot hear Meenakshi.
It was playing earlier. It was fine, so you need to redo it, I guess.
Yes, sir. I'm just redoing it.
Greetings from Sydney. My name's Jim Sullivan.
Now is it audible?
I'd like to thank Professor Shahid for inviting me.
Is it audible?
No.
You'll probably need to undo your audio because if you mute it, then it will stop the voice.
I think that is the reason.
Yeah.
Greetings from Sydney. My name's Jim Sullivan. I'd like to thank Professor Shahid for inviting me to be involved in this webinar series on total hip replacement in dysplastic hips. Been asked to talk about surgical principles, decision making, when and why. Developmental dysplasia of the hip, previously called congenital dislocation of the hip. Dysplasia is used to convey the spectrum nature of the condition. The etiology is usually congenital. The incidence varies in population groups. It is the underlying diagnosis in many young patients presenting with hip dysfunction. And the probability and rate of developing osteoarthritis is determined by the severity of the dysplasia. The eventual outcome is total hip replacement. Classification by Crowe from 1979 grades the subluxation into 4 categories. It's a quantitative grading. Type 2 and Type 3 overlap, and it's the most commonly used in publications. It's based on the degree of migration from the true acetabulum, measured from the teardrop to the junction of the head-neck junction, as then a proportion of the diameter of the femoral head. So less than 50% is grade 1, 50 to 75, and 75 to 100 are grade 2 and 3, and high dislocation grade 4, where the head is completely beyond the acetabulum. The other classification is the Harder-Philokidis classification. It's in 3 categories. One is type A is dysplastic hip, the head's contained within the acetabulum. Type B is overlapping acetabuli, and type C is the high dislocation, as the same as the Crowe 4. This classification separates the different dysplastic stages into different structural anatomical issues that would be encountered at surgery. So it's more of a qualitative classification and is helpful when approaching the surgery, as you can predict what problems you're going to be presented with. So type A and B are primarily acetabular problems presented to the surgeon, whereas a type C is mainly a femoral problem involving femoral shortening to get the hip centre down. Type A, the head is contained within the acetabulum with a degree of subluxation. Acetabulum has a shallow aspect with floor osteophytes and lateral subluxation of the femoral head. There's usually segmental superior defect. There is good anterior and posterior coverage as a rule, and femoral anteversion does not usually present major problems. The approach in a type A is to locate the true acetabulum, identifying the fat pad which is present and the transverse ligament. To do this, you may need to clear the floor osteophytes, and then once you've identified the transverse ligament and fat pad, aim to put the cup near or close to the area just above the transverse ligament and start with a small reamer. It's important to avoid over-reaming and orientate the reamer posteriorly, as the most efficient area of the acetabulum is the anterior wall stop. If the anterior shell is exposed, it may cause acetabular irritation. Type B is a low dislocation, and in this situation the femoral head articulates with a false acetabulum which overlaps the true acetabulum. You see the true acetabulum is down here. There's an extended double acetabulum going all the way up. There's loss of superior wall. There may be anterior and posterior segmental deficiencies. There's a narrow opening and shallowness of the true acetabulum, and femoral version, anteversion may be excessive. In this situation, again, the aim is to try and locate the true acetabulum. The fat pad and transverse ligament will guide you to this, and starting with small reamers, clearing the medial wall osteophyte, and you can see here where the acetabulum should be sitting down here. If bone graft is required, it preferably should be non-structural. So you're aiming to get 70% of host bone contact, and perhaps just, if you've got a 30% uncovering, apply bone graft. The bone graft can be fixed with K-wires or screws before the final reamers are used to create a concentric space for the acetabulum. And uncemented shells are generally very successful in this situation. You may consider using a stem, which you can adjust the version on to correct for some of the excessive anteversion. So you can see here with the acetabulum exposed, there's the transverse ligament, and you want your cup sitting preferably just above, with some variability in how high you go to get good contact with bone. The transverse ligament will also help you orientate the version of the acetabulum, and often the version is a little bit, it tends to be more anteverted than normal. See this case here, previous pelvic osteotomy. It's not possible to get the cup right down to the true floor, and it's not necessary because you can correct for leg length at the on the femoral side, but the aim is to get the cup as close to the true acetabulum as possible so the biomechanics are restored as best possible. Now, type C is a high dislocation. The femoral head is dislocated from the true acetabulum with a varying degree of superior migration. And as you can see, this presents major problems for femoral reconstruction. The femoral shortening is required. There's segmental deficiencies of the entire acetabulum. The AP diameter determines the cup size, and there's usually a narrow opening and shallowness of the true acetabulum. There's excessive anteversion, and the excess of bone buildup in the acetabulum is distributed mainly postero-superiorly. Preference is to use a posterior approach so that you've got an extensile approach for a planned subtrichometeric osteotomy. My preference is to use a stem which has both metaphyseal and diaphyseal fixation, and they can be inserted separately, such as the Ezerom, and generally try and plan to get the femoral head at or below the greater trochanter to accommodate the soft tissues and not over-tension the abductors when the hip is reduced to its true acetabulum. So posterior approach for a planned subtrichometeric osteotomy, we open the elongated capsule and remove the head and trace down to the true acetabulum. You clear the soft tissues, retract the femur anteriorly so you've got good access to the acetabulum. Identify the inferior margin of the acetabulum looking for the fat pad and transverse ligament. Identify the anterior wall to protect it, and you'll see the built-up bone in the postero-superior quadrant. All reamers direct the medial wall of the acetabulum and use a depth gauge to determine how much bone you've got left medially. If you do happen to ream through the floor of the acetabulum, a good technique is to use the back end of a curette and gently elevate the periosteum and then pack bone graft medially underneath the acetabulum. Again, to remember that the cup size is determined by the AP diameter, and you want to maximise the bearing size for stability. During these high dislocations, acetabular bone graft is not required. The transverse ligament is your guide to cup placement. Avoid staying too low. It's a mistake to get too low underneath the transverse ligament, as you'll change the biomechanics of the cup. And again, maximise bearing size. You may consider a dual mobility for stability. My approach is to reconstruct acetabulum first and then prepare the proximal femur and put a sleeve in and put the neck and head into the sleeve and reduce the proximal femoral segment into the acetabulum before doing the osteotomy. When you do this, you'll get an overlapping of the femur over the proximal fragment, and this will give you an idea of how much resection needs to be done. With the hip reduced with the proximal fragment and the femur overlaying, gently traction it to what you think is a reasonable amount of tension. You can palpate the sciatic nerve with the leg extension to make sure it's not too tight. And that allows you then to determine how much bone to resect. Generally, you're resecting between 4 to 5 centimetres of bone. And I have used over the years oblique osteotomies, transverse osteotomies, and step osteotomies. I think it's best not to overcomplicate the osteotomies, and preferably now I used it to transverse osteotomy, perhaps with a prophylactic cerclage wire. After I inserted the femoral implant, I keep the knee and hip flexed to reduce tension on the sciatic nerve until the patient's assessed in recovery. Now, other problems you may present is patients have had previous surgery. Many of these patients have had pelvic or femoral osteotomy. This distorts the bony image and you get angular and rotational changes. Further assessment with CT scans can help you orientate and plan for the surgery. The other issue is the patient's had open releases where they've had damaged abductors, and if the patient's got damaged abductors, this is obviously going to affect their long-term outcome. Patient, 29-year-old female, previous acetabular and femoral valgus and derotation osteotomy. Again, my preference was to use a separate sleeve and diverseal fixation stem such as the ESROM, trying to get the acetabulum as close to the true floor as possible to restore as normal biomechanics to the leg as possible. 42-year-old nurse from New Zealand, she'd had bilateral femoral osteotomies. We did these procedures staged 6 months apart. We were able to prepare the proximal femur for the sleeve before doing the osteotomy, and then doing the osteotomy to correct for the angular deformity, and again trying to create the acetabulum into its true position. And as you can see, no bone grafting was required as there's a reasonable bulk to the acetabulum. Patients had previous hip replacement present other problems. If the hip's been put in a high centre and the acetabulum has not been disturbed in the surgery, you can generally reconstruct this case back to the true acetabulum without major structural bone graft. We've got bone graft in here, but we've got, I think, 60 to 70% host bone contact, which is why the case ended up being successful. Another revision of a high hip centre. Patient had a ceramic on ceramic autophore with what appears to be some degree of femoral shorting with a trichometeric osteotomy. The abductors looked deficient, but we were able to restore the acetabulum to the true centre and then apply allograft. Allograft obviously is not as successful as autograft and should not be structural. And in this situation, again, you can see that probably got host bone out to here, and this structural allograft was successful as it was not taking much load at all. The patient out to 7 years. Other techniques which can be used, and these images are from Professor Hong from Shanghai, is to use an intra-acetabular osteotomy. This situation, you create a cork-shaped medial circular osteotomy in the floor of the acetabulum, punching the medial bone through, and then rely on rim fixation for the cup. In my experience, I haven't had to do this very often, and my approach again would be to try and keep the surgery as uncomplicated as possible, but in very shallow situations, it's something you may consider. So in the past, people were using cemented cups, but they've had a fairly high failure rate after early success. And I think there's been a trend to move well away from this. People also published on using acetabular rings, and you may consider having that as a backup if you're doing some of these very deficient type B hardphylactetes where you've got overlapping acetabuli and you think you may be forced to use structural bone graft. But again, generally, you're able to get away with just using hemispherical cups. And the results on hemispherical cups are very good. with very low failure rates over quite a long period of years, 6-7 years, some of these out to at 14 years, another study showing 90% graft incorporation, but some cup loosening. So in summary, the acetabular considerations hip dysplasia are to aim to reconstruct the acetabular shell into the true or near to the true native acetabulum. Use the classifications such as Hataphylochides to predict the bone deficiencies, aim to medialise the cup to achieve 70% host bone coverage, and minimise the use of structural autograft, although autograft is very successful. Avoid oversizing the cup so you can maintain the anterior rim, and maximise the bearing size for stability. On the femoral side, beware of excessive anteversion in femoral shortening, secure fixation in the proximal fragment before doing the osteotomy so you could control the bone. Aim for the centre of head to be at or below the greater trochanter to avoid overtensioning the abductors. Consider reducing the proximal femoral segment into the acetabulum after you've done the osteotomy below the sleeve to assess the degree of overlap and how much shortening would be required, and perhaps consider doing the simple osteotomies. Thanks very much. I'm sorry I won't be around.
Thank you, Meenakshi. Thank you very much.
I think Abhay, we can go to the next presentation.
Exactly. We'll go on to the next presentation and then discuss the questions. So over to you, Dr. Vijay, for how to differentiate this DDH from other high-riding hips and the solutions.
Right. Can you see my slides?
We can.
Yes, we can.
So thanks very much again, Shahid and Abhay. It's always a great pleasure to be part of this very excellent academic initiative. So great pleasure for me. So today I'll be talking on how do you decode high-riding hips. That seems to be the common problem that we get questions asked very frequently. So first question is, what is a high-riding hip? So it's a long-standing dislocated hip with proximal migration of the femur. Now the real thing is all Pro-4 hips are high-riding hips, but all high-riding hips are not Pro-4 hips. That's the important differentiation that we have to make. You know, in school, in chemistry, they used to say that all bases are alkalis. Sorry, all alkalis are bases, but all bases are not alkalis. So similar to that, all high-riding hips are not Pro-4 hips. So various presentations of high-riding hips that you see, you know, the two classifications that Jim described as well. You know, the Crow classification and then the Hataphylochides classification, they fall woefully short of giving us methodology of managing all these high-riding hips. So these classifications are just insufficient to have some strategies to manage this. And I must say, not a week passes without somebody sending me an X-ray on WhatsApp or email of a very similar looking hip and saying, how would you manage this? Should I do a subtrochanteric sharpening osteotomy? What should I do and what I should not do? So as of now, it doesn't seem to be very clear to everyone as how to manage these hips. And hopefully by the end of this presentation, you get a clear idea of how to go about when you are presented with a high-riding hip. So the first step to do is to differentiate the two basic types of high-riding hips. The classical one is the Crow-4 DDH as a part of dysplasia. We all know that, Crow-4. But the second thing is a Crow-4-like situation, but it's not truly a dysplasia. So the common causes for that would be a post-infective situation, a post-traumatic situation, or any childhood disorder that has been neglected can result in a high-riding hip. So these are and we have to make a very critical differentiation of these two pathologies. Now, this is not an academic differentiation. The strategy to manage these are completely different, and that's the reason why you got to make the differentiation. It is not an academic differentiation. Now, why this is important is that the Crow-4 DDH present with what we now call a sub-infratrochanteric tightness, a completely different pathology that they have in infratrochanteric tightness. Whereas this one, the other conditions which cause a high-riding hip apart from Crow-4, they present usually with a supratrochanteric tightness. And therefore, your strategy is completely different when you want to manage these both situations. And that's the reason why we got to recognize them through X-rays.
So
the two types of soft tissue tightness that we have, infratrochanteric tightness, 2DDH, and supratrochanteric tightness in other causes of high-riding hip apart from hip dysplasia. So the mainstay of management of a 2 Pro 4 would be a subtrochanteric shortening osteotomy because the muscles that are tight or inferior to the trochanter, typically the big adductor muscles, that's what is really the problem. And once you take a segment of subtrochanteric bone off, they all fall into place. Whereas in supratrochanteric tightness, we need to employ a three-pronged strategy. The first is you do an extensive soft tissue release around the hip, which is the mainstay of management. You place the socket in the judicious high hip center, and you sink the femur a little lower than usual, and therefore you sort of decompress the hips. The decompression is got by a slightly high hip center, slightly sinking of the stem, and extensive soft tissue release. So you find that the strategy for management of supratrochanteric tightness is very, very different from that of an infratrochanteric tightness that you get with a classical Pro 4. Removing a segment of subtrochanteric bone will have little or no effect when the patient presents a supratrochanteric segment. And that's the common mistake that surgeons make. You have hydrating hip, people think it's a Pro 4, and they go in and remove subtrochanteric segment, and nothing happens. Still, it is so difficult to reduce the hip. That's because we are not differentiated these two entities. Now, this is an important video which I'd like to show you. To give you a perspective, this is the patient's X-ray as a true Pro 4, as you can see. And this picture shows that I've done the subtrochanteric shortening osteotomy. I'm just trying to show you there is no tightness at all. The true Pro 4 will not have any tightness in the supratrochanteric region. The medius and minimus are not tight. And to illustrate that point, I'm showing you this video. I have done the subtrochanteric osteotomy. I'm not done any releases. I put my trial stem in, and 2 fingers, I'm able to reduce it into the socket, just 2 fingers. And actually, it's unstable. Actually, you can see that unless you give tension from your final reduction, it is the tightness is not supratrochanteric in a classical 4 and in a Pro 4, as you can see that in this video. You can just reduce the Pro 4 with 2 fingers. Now, this is the patient so how do you recognize these two entities? So here's a patient with a predominantly subtrochanteric tightness. You can see is a classical Pro 4. So how do you recognize this by X-rays? The head is above the level of the GT. That's the first clue that you're dealing with this first type of subtrochanteric type of tightness. The second thing is you find that there's no well-formed pseudoacetabulum. The femoral head is not articulating with the pelvis. And the third thing is the lesser trochanter is much higher than the teardrop. So these are 3 important points that you take into account to recognize that the shortening is infratrochanteric and not supratrochanteric. And clinically, you'll find that this patient has got an exaggerated range of movement and a very mobile hip. And thereby, I know that this patient has got infratrochanteric type of shortness. And what do you need for this patient? You need a subtrochanteric shortening osteotomy, and that everything will fall into place. No releases are required. And that's what has been done in this patient. Now, here is the other variety. Here's predominantly supratrochanteric type of tightness, post-infective situations, etc., where you find that the head is usually below the level of the GT. Important point to differentiate from X-rays. The sclerosis of the acetabulum, there's always a pseudoacetabulum there. And you find that the lesser trochanter is almost at the level of the teardrop. These are the 3 cardinal points to differentiate that here I'm dealing with the supratrochanteric shortening, and here the primary modality of treatment is not a subtrochanteric shortening osteotomy, but a 3-pronged approach that we told about earlier. And here the patient has clinically a stiff hip. And what you should do, you should not do subtrochanteric shortening osteotomy. I have kept the socket a little higher. I have sunk the stem very low, and I've done an extensive soft tissue release to manage this. And that's how you manage these conditions. Now, however, we have a combination type. So here is the combination type. So here you find the combination type, or the type 3, the variation of the supratrochanteric tightness. Here you have a stiff hip on clinical examination, and based like we told you about the supratrochanteric tightness. Same principle, the head is below the level of the GT, as you can see here. The head is below the level of the GT. The sclerosis of the acetabulum is well-formed pseudoacetabulum. And you find, however, the LT is not at the level. Here you find that in a classical one, the LT is at the level of the teardrop, but here you find the combination variety that the LT is much above the level of it. So this is a combination type. So this is the differentiation between the combination type and the classical other type 2 types of hydrating hip. So how do you manage a combination type? Here's a patient who had a fractured neck of femur 30 years ago, not a dysplastic. So 3-pronged strategy of an extensive soft tissue release around the hip, a judicious high hip center, and a judicious sinking of the stem. And that's what we have done. And plus you need a subtrochanteric shortening osteotomy. For combination type, you do all this, plus you need to do a subtrochanteric shortening osteotomy. So you can see all that has been done the hip center has been slightly high. You can see how the stem has been sunk really low. You can see that in addition to that, I've done extensive soft tissue release to get the hip down. Plus, I've done a subtrochanteric shortening osteotomy. These are the principles of how you manage a combination type. Another example of the combination type, you can see a classical pseudoacetabulum, head below the level of the GT, but you find that the lesser trochanter is much above the level of the teardrop. And here I have done all these principles of a high hip center. I've sunk the stem low. In addition, I've added a subtrochanteric shortening osteotomy, and that's how the strategy to manage this combination type. Now, this is the one three-pronged strategy. And then, so give you some tips of how we manage this supratrochanteric type of shortening, because I don't want to go into the subtrochanteric shortening osteotomy because Mojieb will be covering it in the next talk. So I'll talk about the supratrochanteric or some pearls, supratrochanteric osteotomy and the combination type. So we talked about a three-pronged strategy, extensive soft tissue release, which we call as a 300-degree release, a high hip center and a judicious sinking of the femoral component. So you have to do an extensive soft tissue release, which we now call a 300-degree release. What is the 300 degrees? You find that the only thing that you leave behind is the abductor mechanism, the gluteus medius and the gluteus minimus. Everything in the rest, you must skeletonize the proximal femur. And that is truly a 300-degree release that you do to bring the hip down, because all your stiffness or all your tightness is now supratrochanteric. That's the first one, the extensive soft tissue release. Now, where is the best bone in these patients who have a well-formed pseudoacetabulum? So according to Wolff's law, we know that the bones in a healthy person will adapt to loads under which it is placed. So the best available bone is where you see the sclerosis. And therefore, a judicious high hip center is a good idea in these patients because they have a well-formed pseudoacetabulum. That's probably the best place to put the socket. So here's an example of that. The best bone is the bone that's loaded, where you find sclerosis. And that's what I have done. You can see that. And the socket is in the best available bone. And that's why a judicious high hip center is an excellent option in these types of hydrating hips. And the next question to ask is, how high is judicious? How high can go the high hip center? Now, typically, a rule of thumb is that the lower border of your socket must generally not go above the top of your teardrop. So that's the rule of thumb that we have. Generally, we see all my cases, you don't want to go very high. The lower edge of the cup must not go above the top of the teardrop. That's a good rule of thumb. And you can see in all these patients, it's like that. You can see that we don't go above the level of the teardrop. And that's a very good, useful rule of thumb to manage these cases. Now, very interestingly, the same concept of the best bone stock holds good even for a Crow 4 hip. Here's the classical Crow 4 dysplasia. And in the CT scan, you know that the best bone is not above, where we do where we keep a high hip center. The best bone of Crow 4 is the true center. And that's why you want to keep the socket at the true center, because that's where the best bone is. The rule of keeping the socket in the best available bone holds good for Crow 1, Crow 2, Crow 3, and Crow 4, because that's where the best bone is, and that's what we want to respect. Now, we talked about judicious sinking of the femoral stem. So you can see that the femoral stem we are sinking now. You can see my sleeve of the S-form almost below the lesser trochanter. So we want to employ the strategy that in the non-Crow 4 hips, the hydrating hips, that's what we want to employ. And you can see that we are really sunk very low. Next question to ask is, how much of sinking of stem is good? So typically in the combination type, example, if you see here, that's the abductor that you have done. And typically if you see this X-ray, the center of the head is below the level of the tip of the GT. Okay, you can see that. And that is the strategy that we are sort of employing to decompress the hip. High hip center, sink the stem, and decompress this tight hip. Okay, now how low can you go? Now that is the top of the trochanter. That's where ideally the head is placed. But now we are placing it slightly lower. But you certainly don't want to go below the half of the GT. So that's your rule of thumb again. You can place the center of the head up to the half of the GT. But if you go below that, biomechanically it will become a very poor hip. So you can go the center of the head up to half of the GT. And that principle that we got to respect. Now, just to illustrate this point, I put a Crow 4 and I've done a Crow 4 reconstruction. And you can see that the center of the head is much above that of the GT. That's what you want ideally in a Crow 4. You must not sink it down. Whereas in non-Crow 4 hydrating hips, you want to sink it down because the pattern anatomy is different and you want to decompress the hip by sinking it. So it's quite different from a Crow 4. So prerequisites of stem used in hydrating hips. So whenever you have a hydrating hip, we all know that we must use stems like the cone Wagner or the S-form. We are all well aware that these stems have 360-degree versional freedom. That is the well-known fact. But what some of the surgeons don't, still not well known, is that it has got a tremendous craniocaudal freedom. So both the cone Wagner can be left very low in the femur, can be left very high in the femur. Similarly, a S-form can be left very high, can be left very low. Whereas if you have a standard stem like a Kodai, for example, you have very little, you have about a centimeter of craniocaudal freedom, and that will not suffice when you deal with a hydrating hip. So you must opt for a stem that's got a good craniocaudal freedom, which would be the cone Wagner or the S-form. So here are examples in which I left the stem very high, and other examples in which I have left the stem very low, demonstrating a very high craniocaudal freedom. So in conclusion, I'd like to say, you must learn to differentiate the two entities pre-op. So have a correct strategy. If you employ the wrong strategy, you're going to run into serious trouble during the surgery. Both have different pathoanatomy and therefore different management strategies, which you must pick up on X-rays by the clues that were just outlined. A subtrochanteric shortening osteotomy is an elegant method of dealing with a hydrating hip with significant amount of subtrochanteric muscle tightness. That's the classical Crawford dysplasia. 300-degree soft tissue release, judicious high hip center, and a judicious sinking of the stem constitutes a three-pronged attack to deal with a supratrochanteric tightness, with many examples that I showed. This three-pronged strategy is combined with the STSO for a combination type of a hydrating hip. So thank you for your attention. Thanks very much.
Thank you so much, Dr. Vijay. That was a master talk as usual. Your extensive experience on dysplastic hips. So there's a question on the chat box, and they've asked that, do you need to sink all the stems in the patients where you have the non-dysplastic, non-DDH hips? Or
yes, that's your main strategy. Yeah. So you never sink it in a Crawford hip, but a non-Crawford hydrating hip, you have to sink it down, keep your hips in high, and do a release. And that's your main strategy of dealing with non-Crawford hydrating hips.
Okay, and there's another question which says that how do you differentiate between a Perthes which has become symptomatic versus a dysplastic hip which has become symptomatic at the same stage, and does it have a bearing on the treatment? You've already covered it with just a quick recap of the points.
So the Crow2, Crow3 post-Perthes disease will all have a big head, mushroom head. In contrast to all Crow4 and Crow4 variants, it will have a mushroom head. So the socket will be quite a mirror image of the big mushroom head in Crow2, Crow3. It can be quite difficult to differentiate a classical Crow3 from a post-Perthes, but the principles of management are essentially the same. So there is no great advantage in trying to differentiate those two entities. Can be difficult at times. Okay, so Professor Shahid, sir, would you?
Thank you very much. I think we can have 2 or 3 lectures that are overlapping, and then we can take discussion, and we can have discussion among the faculty as well.
Sure, sir. So may I invite Dr. Mojieb for his talk on STSOs, planning and execution. Why, when, and how?
Good morning. Good morning, good afternoon, and good evening, everybody. And thank you very much, Shahid and Abhay, for inviting me. I'd like to talk about subtrochanteric shortening osteotomy. Can everybody see my screen?
Yes, sir.
You can see your screen.
Okay, I'm just putting, Okay, so just want to minimize this. Okay. So we got instruction from our organizers to keep the talk very much case-based. So I would like to start my presentation with a case. This is a gentleman who's an engineer, and he's 52 years old and has been having a childhood dysplasia. As you can see from X-rays, he's gone to multiple physicians in different parts of the world. He ended up getting an ankle fusion. And then he got some kind of a derotation diaphyseal osteotomy with what people probably suggested to him like a shelf procedure. And I think he came to the end of the road where he definitely needed a total hip arthroplasty then for his Crow type 4 dysplasia. So, we took him to the OR, did typical subtrochanteric shortening osteotomy that helped us to bring his hip down to the true center of the acetabulum, as well as perform a derotation. We kept that osteotomized fragment and we used it as a vascularized bone graft. And the patient did very well. And here is an X-ray from 6 months post-op, and you can see there's well consolidated fragment at the top of the side of the osteotomy. Another gentleman who's much more younger, he's 41, works as an interpreter, came with what you could say is kind of a crow 3 minus, excessive anteversion of the femur. He had polio on the right side, and we took him to the OR to do a total hip. We were fully prepared to do a derotation type of subtrochanteric osteotomy. So in this case, a subtrochanteric osteotomy would have been indicated for a derotation and not necessarily for shortening. As you can see that we were able to bring out his leg to equalize his leg length without the needing of any shortening osteotomy. We, with the use of a cone type of femoral stem, we were able to dial in lesser degree of rotation, and we were able to minimize his anteversion, and we did not have to use any kind of subtrochanteric shortening osteotomy. And as you can see, this is 8 months. The femoral head allograft has completely united and consolidated to his native acetabular bed. So I think like any total hip replacement, the indication would be pain, pain, pain. We got to look at images and make sure that there are no other causes apart from the dysplasia that are causing the pain in this particular patient. The gentleman with the polio, we had to do a neurological clearance, making sure that there's no other cause from his lumbar spine that is causing his ongoing pain. Obviously, like the previous speakers have mentioned, the complexity and the difficulty of any reconstruction in these dysplastic hips go proportionally with the degree of anatomic abnormality, for which there are various classifications. The most commonly known are the Crow classification, and the subtrochanteric shortening osteotomy is most commonly used for type 4 and to some degree of some cases of type 3, which I believe will be mostly indicated for dialing appropriate anteversion rather than shortening. The same thing applies for similar classification by Hartophylakides, which is type C, that's equivalent to type 4. And the commonest femur pathoanatomy is that the femur is lying superior and posterior. There's excessive anteversion, and obviously the femoral neck is short, excessively anteverted, and the entire femoral diaphysis is very hypoplastic, narrow, thin. And this is commonly seen if you do an epipelvis view with people who have got a unilateral kind of Crow type 4 dysplasia of the hip. You can see the degree of atrophy, degree of how thin the cortices are on the affected side compared to the normal side. My mentor, Dr. Duncan from UBC Vancouver, Canada, always taught us that the proper pre-op planning starts from the time you have booked the patient and not when the patient is sitting on his operating table. In addition to the clinical examination, where we got to assess the degree of leg discrepancy, I usually go very classical by going from ASIS to the medial malleolus and from the umbilicus to the medial malleolus. I also do full-length x-rays from hip to ankle. In the old days, we used to insist on getting them on a 51-inch cassette and not a 35-inch. These days, with the digital images, they all do stitching. And the way patients' patella are projected to be facing directly anterior, and also sometimes we got to give patients some blocks to equalize the pelvic tilt to make sure that we can get an accurate assessment of what's the degree of leg length discrepancy. You can also use more sophisticated CT scanogram to assess the leg length discrepancy, but the CT in my practice is predominantly kept for assessing the degree of the bone stock, particularly on the acetabulum side, degree of anteversion, and where is the acetabular deficiency. Again, this example of preoperative planning when we are trying to assess the degree of lengthening that we need to correct preoperatively. This is cases of bilateral DDH type 4. And if you look at this calculation, if we need to bring the hip center down to the true native acetabulum, that's about 5 centimeter. And then you subtract the degree of the actual lengthening that you have to do to equalize the shortening that the patient is symptomatically suffering from. So if you look at this is the template showing that the average distance that needs to be brought down is 6.5 centimeter. The patient has got 2 centimeter of leg depth discrepancy, and by doing an osteotomy of resection 4 centimeter, you'll be able to get the head down to the hip center without endangering the sciatic nerve. The technical difficulties on the femoral side, as we mentioned, that the head is usually sitting up and posterior. Neck is narrow and short. There's a marked anteversion. Most critically, the GT is greater trochanter is actually short and sitting posterior with a narrow canal. On the acetabulum side, we're looking at a very small acetabulum. I think in our parts of the world, it's not very uncommon to find people with DDH getting acetabulum sizes of 42 and 43, which makes it difficult to put a size 32. Sometimes we're limited to put a size 26 or 22 head. Obviously, the acetabulum could be deficient superolaterally and anteriorly, and the worst changes are seen in high hip dislocation. I think on top of the bony deformity, what need to kept in our mind is the soft tissue changes, and the soft tissue technical challenges are very detrimental in how the operative technique will be implemented inside the OR. So the abductors could be tented over the femoral head. There's the psoas subductus and rectus femoris tightened to different extent. I think Vijay very elegantly showed the difference between the supratrochanteric and subtrochanteric tightness. Capsules are usually thickened, elongated, and most critically is our sciatic and the femoral nerve that are short, and the whole STSO has been developed to prevent any femoral and sciatic nerve palsies from occurring. The type of femoral implant, as Vijay mentioned, it's either a modular type of femoral implant that gives you the option of turning the proximal femoral component 360 degrees in any type of version that you think will be appropriate to that particular patient. And that will be supplemented with a distal femoral stem, which could be used as a distal fill or fill and fix both. I personally use the femoral cone type of implant that gives me the freedom of turning it either in any degree of antiversion. I can also control the degree of how deep I implant it, and it's more user-friendly than the modular system. I have no experience with the cemented small femoral implants, but I know that there have been publications from Greece in particular that have looked into using the cemented small femoral components with setting of the STSO. My concern with that is the cement would come into a site of osteotomy, will be a cause of non-union. I go with a posterior or posterolateral approach. This is the way the patients are positioned. I always keep ECG lead here, ECG lead button that will help me to find the exact pole of the patella, and that will be a good reference intraoperatively for me to assess post-implantation or post-trial implantation, how far I've been able to successfully lengthen the affected hip. And this is a way to assess your femoral antiversion once you have put your trials in. So this is just a very short technical operative details. Once you have done a posterolateral approach, I like to do a capsulotomy, resect my femoral head and save it to use it as a morselized autograft that I can use at the site of the trochanteric osteotomy, or if the head was deficient superiorly at the time that I wanted to use this femoral head as a morselized, as a structural autograft for the acetabular head. You got to do the reaming and the broaching of the femur with a trial prosthesis inserted before you commence any kind of subtrochanteric osteotomy. So you have their femur, I wouldn't say dislocated because it's already dislocated, but the femur is delivered into wound. You have taken off the femoral head. You go ahead and start with the reaming, broaching, and you got to ream more than the length that you anticipated because you'll be taking anything between 2 to 3 centimeters of the femoral segment. So your reaming got to go much more deeper. You can either be lucky and you can reach the acetabulum, and then you just go ahead and remove the fibrous scar tissue, take away all the osteophytes. You can use the transverse and round ligament. But if you had difficulty in not being able to get to the acetabulum, particularly that sometimes you get confused that you're either sitting too anterior, so you're actually in the anterior to the anterior acetabular wall because that wall is also deficient. I think the best thing at this point of time is to go ahead and do your transverse femoral osteotomy because you're going to do them anyhow. So do not delay it, and don't, I prefer not to be messing with the soft tissue, not knowing what I'm going to get into. I go ahead and do my transverse femoral osteotomy, which is about 1 to 2 centimeters distal to the lesser trochanter. And in doing so, I do minimal periosteal stripping. So the periosteum that I strip is equal to put the width of my saw blade, so no more than half a centimeter or 3 to 4 millimeters. So I put my first or the proximal part of my osteotomy, and then I move the entire proximal femur and I push it over anteriorly, and this will help me more to identify and go down to my acetabulum. This is a graphic representation. I brought it from the article of Dr. Berry from Mayo Clinic. So this is the first osteotomy. You go ahead, do reaming, broaching, or just reaming. For example, in the Wagner cone, you just do the reaming, and then you do your osteotomy. And once you have done your osteotomy, you would have then gone ahead and do your acetabular preparation. You put your trial in the proximal fragment only, and then you reduce your hip. You apply a gentle traction, and you assess the degree of overlapping of your distal fragment to the proximal fragment, and this will be equal to the osteotomy fragment that you should be resecting. And this should be going more or less with the planned or with your preoperative planning, keeping in mind that this should not exceed more than 3 centimeters to avoid any sciatic and femoral nerve palsies. Once you have done that, and then you can go ahead and do a trial reduction with a trial implant. You can also dial your version, which is about 20 to 30 degrees of anti-version with the proximal femoral component. And once you have done that and you're happy with the degree of tension that you have in your sciatic nerve and your abductors, and you have done your stability check, you can go ahead and remove the femoral trial from the distal fragment. You need to smoothen the distal fragment so that there is a minimal gap, as minimum as possible. Then you put your actual implant, and then you apply your osteotomized fragment. So the osteotomized fragment needs to be split longitudinally. You maintain the vastus attachment, and then this will function as vascularized graft with morcellized graft that you can take from the femoral head, and you can apply it here into the gap of the osteotomy. And then the cortical fragments that are applied here as a strut graft are going to be tightened using either a cable or a circlage.
Dr. Mojieb, so we need to wind up. We're running slow on time.
Okay. So this, once you have put fixation, that could be either a cable or a plate, you need to do a stability check as well. This is another example of strut graft applied with a circlage only, not a plate, with a good osseointegration at 6 months. This is femoral graft. And in terms of osteotomy, as we know that the whole idea of doing the osteotomy as a subtrochanteric is to maintain the abductor attachment, gluteus minimus and medius, as Vijay mentioned, in compared to the other kinds of osteotomy, which were the greater trochanteric osteotomy followed by attachment. There are other types of osteotomy as well, like the double chevron or step cut. There has been no difference in terms of non-union rate, nerve palsy, and dislocation. In terms of non-union, it's basically been shown that if you do excessive periosteal stripping, you got that could be causing non-union. Resection size usually 30 millimeter. If it's between 15 to 30, you got to fill in the graft and put strut autograft. The stem has to be well fixed and long enough to fill in your distal fragment. Fractures can also occur due to any mismatch of proximal and distal fragment. If your canals are thin and narrow, particularly if you have any deformity. One way to come over and prevent any fracture is to put a prophylactic circlage in the distal fragment. If you have any kind of change in version or the components were not put in appropriately, that might cause dislocation. Non-union and abductor damage can also be factors in causing dislocation. Whether you put the graft anteriorly, mediolaterally has shown to have no difference. The long-term results of cementless arthroplasty with type 4 with a subtrochanteric shortening osteotomy showed a Kaplan-Meier survivorship of 97% from this study coming out of China. So the cementless modular or monoblock using a cone type of cementless system has shown a very good acceptable result. The take-home message is that there are two different types of dysplasia, the low and high dislocated ones. The capsule and soft tissues are contracted. Our aim should be to restore the center of rotation, and we got to respect anterior on the acetabulum side. Bone grafting techniques both for acetabulum and for subtrochanteric osteotomy, they're reserved for type 3 and 4. What type of osteotomy does not matter, and what type of fixation, whether you use a plate with unicortical screws or you put circlage cable, it doesn't matter. And make sure that you do apply strut graft with a morcellized bone graft filling the gap of the osteotomy. Thank you very much.
Thank you so much, Dr. Mojieb, sir. That was actually fantastic. And we have lots of questions, so I'll split the questions to between talks. And the first one is for you. How does a STSO differ between that of a standard dysplastic hip versus that for a deformed femur?
So is it for me or for Vijay?
So we start with you, and we'll take Vijay's opinion on this.
So if you have a type 4 crow without a deformity, then you just do a subtrochanteric transverse type of osteotomy. If you have a deformed femur, then the osteotomy could incorporate the correction of that femoral deformities. If you have this excessive valgus femur, you can do kind of a wedge type of osteotomy, which will be taking much more from the medial side. So it will be like the base of the wedge will be longer on the medial side compared to the lateral side. And this will be able to correct the wedge. So then you'll have a more straightened femur rather than the angulated femur, and then you can change the version through that osteotomy plane.
Vijay, anything else to add on this? Would you do it differently, or would you do the same?
No, it's exactly the same thing as Mojieb said, but the only thing, the amount of the dissected bone can come from either fragment. So once you make the osteotomy and then you can take bone from the proximal fragment as well. So it is not a rule that you must take it from the distal fragment. So depending on what is the situation, you can take from the proximal bone as well, or from both if required. If your osteotomy is little different from where you plan.
There's another very good question, and I would like to bring Dr. Takeshi into on this. And this question says that how do you deal with a plate which has been inserted for an osteotomy done in childhood, and that plate is actually got incorporated or been covered by bone? So how do you deal with that situation, and does it affect your performing an STSO and removing the plate? So question to Dr. Takeshi first, and very quick comment from Dr. Mojieb and Mojieb later.
Well, I would try to remove the plate or the screws. Most of them are stainless steel, and it's much easier to remove than the titanium plate and screws.
Would your osteotomy be any different with a plate and without a plate situation?
No, not different.
Dr. Mojieb, sir.
If the plate is at the osteotomy side, you're going to be bypassing the screws anyhow with your stem. The stem is going to be long enough to bypass the screws and also to minimize the chances of non-union and the fracture. My only concern would be that if this plate was one of those titanium ones, those are the ones that are likely to break. Those are the ones that the screw head will strip off, and then you'll be left with a screw shaft going through your canal. And if that's happened, and I know that it's a titanium plate, I would have warned the parents or the patient that I'll do this in 2 stages. But if I find this, and this is something that was a sudden intraoperative findings, then I'll just go ahead, remove it. And if removing the screws ended up requiring a larger bone defect that I won't be able to manage and bypass through a femoral stem, then I may just graft it and do this in 2 stages.
Great point, sir. And another question is that does a distal deformity, so suppose you have a deformity in the mid or the lower third of the femur, how does that affect the planning of your dysplastic hip total hip replacement? So may I get Dr. Takeshi and Dr. Tanveer, sir, on this? Very quick comments from you on these 2 questions.
And it depends on the location of the deformity. If it's a distal, I do the distal femoral osteotomy. It's in the mid shaft, I may need to correct that deformity.
And would you do the distal femur deformity correction in the same stage as the total hip?
Yeah, no. It's usually 3 to 4, 6 months separate.
Dr. Tanveer, sir?
Yes, I think it's the same. I would come for the first question about removing the plate. I always plan that as a 2-stage procedure. So in the first stage, remove the plate, and then second stage, go ahead with that one. And the answer to your second question, yes, again, it's a 2-stage procedure. You do the corrective osteotomy in the first stage, and then you come back after at least 3 months after that to do the second stage.
As a last question that I would like to allude to, and Vijay, can I get you quickly onto this? Is there a difference in how you plan and between a hip which has a pseudo acetabulum and versus that which does not have a pseudo acetabulum? So do these 2 hips behave differently?
Yes, they do very much, as I outlined in my talk. So pseudo acetabulum is where the best bone is. So you'd like to incorporate that in your socket, non-central socket fixation. Whereas when there's no pseudo acetabulum, the best bone stock is in your native center, and need to bring it all the way down. So it's fundamentally different concepts involved there. Abhay, can I add a point regarding distal femoral deformity?
Yeah, sure.
Somebody's got a rotational deformity of the distal femur or the midshaft femur. Now remember, when you do a subtrochanteric shortening osteotomy, your stem aligns only to the distal fragment. It's got no relevance to the proximal fragment. So if it's a minor deformity of say 20-15 degrees of rotation, you can incorporate that by rotating your stem. Should be very easy to do, and you don't need a second procedure. So remember that you don't have to match your osteotomy rotationally. The stem is in always in relation to the distal fragment and not the proximal fragment. I hope that's
great points. Thank you so much, Dr. Vijay. Let me, so we quickly move on to the next, which is a case-based talk. And let me invite Dr. Mansoor sir to give his talk on socket side classification and how it has a bearing on restoration of the central rotation of the hip. Welcome, Bodo.
Shall I start my share screen?
Please do that.
Okay, Assalamualaikum. I'll be looking at the acetabulum side and the dysplastic hips. A lot of my talk has already been covered, so I will move faster than I was thinking. This is where I work currently. It's a 350-bed hospital expanding to 1,800 beds in the next 2 years, and it's a network of a number of medical institutions across the country, which are all free for the patient. We provide free of cost care, and I hope if you're in Pakistan, you can come and have a look at it. Now, acetabular dysplasia, usually undetected in most patients, and osteoarthritis symptoms draw attention to it. However, it can be a residue of earlier unsuccessful DDH treatment. Now, this patient, one of ours, he had no symptoms, and as a younger person, and when he crossed his 30s, he started to have discomfort, and you can see sclerosis and cyst formation above the left acetabulum. He was more symptomatic on the left side. He had no idea that that he would have a problem as he grew up. This patient presented much earlier, and this patient had symptoms in the 20s. This was a patient who had early treatment because of dysplastic hip. This patient had no recall of any treatment of any problem and presented in the late 18, 19 years age. Now, as I said, it's initially asymptomatic and pain precedes joint failure. Mainstay obviously have been X-ray images. MRI is better if you want to think about that, use a better image of the acetabular labrum and the cartilage. The CT scan definitely helps. I prefer it also. Most authorities prefer that because it gives a 3D appearance of a 2D, the X-rays give a 2D appearance of a 3D deformity. And a CT scan sort of corrects that and gives a 3D impression of what we're looking at. Joint preservation surgery has a huge amount of literature. We won't be looking at that. Now, obviously, as the previous talks have shown, THA represents a massive challenge, the distorted anatomy, acetabular and femoral, limb length discrepancy, younger age of the patient, and obviously maintaining soft tissue balance. There's a whole galaxy of problems on the acetabular side, and these are probably just some of them which can be present, and these have to be kept in mind before any kind of arthroplasty has to be attempted on the acetabular side. The classifications, Crow, Hartov, Achilles, Iftikhar, and Kabul. I'm quite familiar with the Crow, have some experience with Hartov, Achilles, Iftikhar, and Kabul I've just read about. More rarer ones such as Gans and Cochin, I'm not really familiar with. This is now the X-ray showing a 2D assessment of a 3D problem. You've got to remember that. And it shows how to calculate 1, 2, 3, and 4, depending on the amount of subluxation and the dislocation, and relating it to the pelvic height. The Crow classification, if it's Crow 1, less than 50% subluxation, or 0.1, or less than 0.1 of pelvic height. Crow 2 is 50 to 75% of subluxation, and it's 0.1 to 0.15% of pelvic height. Crow 3, 75 to 100% subluxation, 0.15 to 0.2 of pelvic height. Crow 4 is greater than 100% subluxation, or proximal dislocation, which is greater than 0.2% of pelvic height. Hartov seems a bit more simpler in these basic types: dysplasia, low dislocation, high dislocation. But if you look at it in the greater detail, it's actually much more elaborate and defines the problem on the femoral side as well, what deformity deficiencies we can be facing. Iftikhar and Kabul, I've had not much experience with this, but divided in A, B, and C. Looking at the center of rotation, that's very important. This is the easiest image I found to explain what is the center of rotation for most people. Now, this is where the whole thing is going to be revolving around. And finding the center of rotation in an acetabulum which is grossly deformed is actually not easy. Finding the center of rotation in doing an arthroplasty in a normal acetabulum is actually not that hard. Just need to try to match the abduction and anteversion of the native acetabulum, and in most cases, that's quite easy to do. Finding the hip center of rotation and deformity of an acetabulum can be difficult due to shallow, proximally migrated acetabulum altered bone stock, retroversion, and muscle imbalance. Now, if the lateral displacement occurs of the acetabulum, we increase the load by 0.7%. Superior displacement increase the load by 0.1%. So it's best to medialize the cup and avoid superior cup placement. There are limits. We can go 25 millimeters in either direction. That seems to be the upper limit, though some authorities feel 30 millimeters is a better option. This is the patient we saw earlier. Compared to the good hip on the right side, the left hip has a much higher center of rotation. This is one of our patients, a 45-year-old female, bilateral dysplastic hips with hip osteoarthritis, high riding hip centers. It is higher on the left, lesser so on the right. Now, but this may not seem to be the ideal case, but she underwent total hip replacement in one session through anterior approach. The hip center on the right side is quite normal. Left is better than before, but still a bit higher. We managed to medialize the cup, and there seems to be a little bit of space still above the left acetabulum, which we can see there. The high hip center may seem to be a good option, but as it utilizes living host bone, that's very good. But it can produce weak abductors, excessive joint reaction force, producing increased wear, component loosening, and even dislocation. Now, finding the center of rotation seems quite difficult in these hips, and Zhang et al., their work published in the Journal of Orthopaedic Surgery and Research, 2019, defined the fossa and the acetabulum into 4 different types to find the center of rotation. In acetabulum and what is called a crack-shaped fossa. And these two lines joining the base of the acetabulum with the center of rotation to be found about 29 millimeters or 30 to 25 millimeters, depending on the size of the patient. Sorry, this is 1. This is 2, which is a closed type of fossa. Crow 3, the acetabulum is shell-shaped and the fossa itself is triangular shaped. Crow 4 is the acetabulum itself is triangular shaped and the fossa is shallow shaped. And using all of these to draw this perpendicular to the line at the base of the fossa, and from 25 to 30 millimeters, you find the center of rotation. Acetabular exposure is very important. This is the kind of retractor we sort of rigged up at our institution, where we use a standard channel retractor, but we use 3 Hohmann retractors. One which is anterior over the superior pubic ramus, second to push the femur posteriorly, third distally, and these are tied with simple ribbon gauzes, and this gives a pretty good hands-free access to the entire acetabulum. And here, if you want, you can calculate the center of rotation using the measurements as shown by Zhang. Now, acetabular reconstruction for these kind of hips, there's quite a lot of options. For example, if you look at A, that's using the standard high hip center approach, living bone graft. But if you take it too proximal, then obviously shifting it to proximal alters the loading on the hip joint. Using an autograft is quite helpful if you have the femoral head available, and this utilizes patient bone to cover the uncovered femoral, the acetabular component. Bone grafting can be done, or spongioplasty, as it's been called, to cover the uncovered acetabulum. This is a technique I'm not familiar with. What is described as a living bone graft, but I've included in this illustration number D, using segment of the iliac crest with a muscle pedicle flap kind of thing. This is in E, using an acetabular reconstruction ring. F is using a titanium augment superior to the acetabulum. G, H, and I are basically kind of the medial protrusio technique in which cortiloplasty has been done. In G, it has been with the chisels, H with the reamer, and in I, simple protrusio through the medial floor without any kind of bone grafting. This is using the femoral head as an autograft. This courtesy, I've asked Dr. Shahid Noor for this image. I did not have a very good one. We have used this technique before. Thank you, Shahid, for this image. And here you can see this the follow-up image. The femoral head has been quite well integrated and the cup is well in position. Acetabular rings can be used, but there's a whole option of what is available.
Mansoor, sir, I think we are getting short on time, so may I just request you to wind up the...
Just finishing. Just finishing. These are the types of trabecular metal, which is basically sponges made of titanium, allowing bony ingrowth. This place superior to the acetabulum to enhance coverage. Hip preservation is ideal for young adults, and obviously, dysplastic hips will require an arthroplasty. It's quite faced with quite a lot of significant deformity, muscle weakness, Classifications help in planning, and finding the center of rotation is very important. Understanding of biomechanics is essential to achieve successful long-term outcome. Thank you.
Thank you very much, sir, for a very lucid illustration of the key important points. And a lot of this is going to be a repetition, so the more the better. So before wasting time, we'll collect our questions, and I have a lot of questions pouring in, but let me just invite Dr. Gokhan for his talk on the femur side, choosing the right stem. Dr. Mansoor, sir, you'll have to unshare your talk.
Yeah, there, sorry.
Hello, may I share my
yes, please, Dr. Gokhan. Please go ahead.
Can you see it?
Yes, we can.
Okay. So good afternoon from Turkey to everyone. I will talk about the right stem, the choosing of the right stem in dysplastic hips. First of all, as we all know, the dysplastic hips has more problems than the primary hips, like proximal and distal mismatch and anterosion problems. The canal of the femur could be very narrow. There can be any deformities or angulations due to the previous surgeries. And of course, the stability is the major problem for us. In our country, we use two major kind of stems. The first one is the Zweimuller type stem, and the other one is the Wagner cone stem. If you talk about the cone type stem, it's a tapered cone. It has a freedom in controlling version. It has 4 wings for trial, but 8 wings for the primary stem. So it's very good for stability. It maybe has less interpretive fracture risk. In this type of stem, you ream and insert the stem. That's it. Zweimuller type of stem, it's tapered also. It has a rectangular design. It has grit blasted coating. The fit without field surgical technique is used for this kind of stem, and it may have higher perioperative fracture risk. In this type of stem, you broach first and insert the trial or the primary stem. If you look at the Zweimuller type stem, it has a 4-point fixation on the axial plane, and it has a 3-point fixation on the sagittal plane. Zweimuller stem in my hands has more rotational stability. It maybe have more advanced surgical technique. Wagner cone type stem has less rotational stability and easier surgical technique. So I prefer to use Zweimuller type stem if I can. First, the entrance of the canal of the femur is done before the osteotomy. It's easier to do it. After the entrance, we go on with the transverse osteotomy, shortening osteotomy. According to the length of the stem or the size that we use, we perform the osteotomy 7 or 6 centimeters distal from the greater trochanter. After the osteotomy, proximal reaming is done, and you reach the preferred size of the prosthesis. After that, proximal reaming or broaching, the major resection is done. You can also use the major resection technique due to the preoperative planning, or you can also do the resection by overlapping technique that's told here before. After the resection, we always use prophylactic cable application to get in front of the intraoperative fractures when we are reaming the distal part. After the prophylactic cable application, the distal parts of the femur is reamed with measured. We always want at least 6 centimeters insertion of the distal femur, 6 centimeters in the proximal femur. Then trials are done, and you are examining the osteotomy site and stability and the stability of the hip. I have some tips and tricks I want to talk about. First is if the stability is good enough, there is no need for fixation or grafting of the osteotomy site if you are using the zwanular type of stem. Another tip is that a length of more than 7 centimeters or more than half of the stem is below to the osteotomy level is not recommended for better radiological union and conclusive better clinical results. Because if you have more than half of the stem inserted distal to the osteotomy site, you will have radiolucency and cyclosis on the osteotomy site, and it is related to the lower Harris-Hip score. Another thing that I want to talk about is the more than 70 of the patients we used sizes -3, -2. So be sure that you have -2 and -3 sizes in your equipment site before the surgery. Prophylactic cable is important. It's really decreases the intraoperative fracture rate, so it's easy to apply and it's easy to use. At the end, if you cannot have or if you cannot achieve rotational stability, you can use plates, you can use grafts, or you can use trochanteric cables or plates. So that's all that I want to talk. Thank you very much.
Thank you, Dr. Gokhan. Nice, crisp, sweet talk. And I have some questions and I'll combine these talks. So may I just bring in Dr. Takeshi, Bodo, and Dr. Gokhan on this? The question reads, how do you deal with situations where you have a proximo-distal mismatch on the femur and you are using a modular stem where the sleeve is not going in? What would you do? And would you change your stem? Can I request Dr. Takeshi to come in, please? And then may I request Bodo to come in on this, please? Dr. Takeshi, are you there?
Yes. Yes.
So
I'm here.
So what would you do in a situation where you have a proximo-distal mismatch on the femur?
It sometimes happens. I always put a plate on the lateral side to enhance the stability of rotational stability and bending resistance.
The question specifically, I think, is for an S-ROM stem also, where they say that if your sleeve is not going in and you have a proximal-distal mismatch, then what would you do? Would you change your stem or would you do something for the femur?
No, I put a sleeve as large as possible, and also I can change the size, and also I insert the matched stem. But if there is some rotational instability, then I put a plate. Always, I usually always put the plate on the lateral side to prevent kind of some instability, or especially rotational instability.
Can I quickly get in Dr. Mojieb also on this? So would you do anything differently, sir?
No, I think the only thing I would do is that if the mismatch is in terms of surface of the distal and proximal fragment, so I'll smoothen it, like Rana saw again, make sure they're smooth, so they're opposing as much as possible. And then if I'm not happy with my strut and cerclage, then I'll go to the plate. The problem with the plate that I face is that I find that makes the whole concept very bulky.
Great. Dr. Vijay, anything to add on this?
Yeah, this is not an uncommon situation. So the two things that we have is, of course, you can use a high-speed burr to sort of burr out your sleeve for your S-ROM. You can also make a small expanding osteotomy of the proximal femur to accommodate your sleeve. So those are two things we have. But one thing you don't do is don't undersize your stem. You can't do the reverse. You can't undersize your stem to accommodate your sleeve. You always have to expand your sleeve to accommodate the stem size. So that's the rule that we have for trochanteric shortening osteotomy.
We have David Chun as a faculty.
Yes, so I have a question specifically for David, Dr. Shahid, sir. And the stem
Vijay, if you allow me just to make one comment, I think it's good because you're an S-ROM user. I think a lot of people get confused between the S-ROM stem and the non-S-ROM modular type of a stem, where the S-ROM stem, although starts from small to large, but they are predominantly a fill, but they also have a fixed variant, right, Vijay? So because if you put an S-ROM stem that has just to fill, it may not get a good osseointegration, and therefore will precipitate a rotational stability as well as a non-union.
That's very correct, yes.
So I have a question.
That's the typical point in SROM.
Yeah. Thank you so much, sir. So I have a question which says, is a cemented stem an option for a dysplastic femur reconstruction? And another one that would you be, for diehard users of the cemented stem, would you be able to use it in a situation where there are deformed femurs? So can I quickly get in Bodo and Dr. Chun on this? Your comments.
So first, David Chun, I would request that your comment that you are a master of using cemented hip arthroplasty. What is your experience in dysplastic hip?
Well, actually, Shahid, my experience is that I've used both types. I've used SROM as well. I would say that actually the problem with using some kind of cementless implant is that all cementless implants at the beginning are inherently unstable. The SROM in particular, because of its proximal jut and no fixation distally except for any point contact you get, is an inherently unstable implant until you get osseointegration. So you need to put plates and stuff to stabilize it. And that inherently makes your job more difficult. You're also trying to put what is relatively a large cylindrical stem into perhaps a very narrow canal with a proximal, your metaphysis comes to cone very proximally. So you ending up with very small, short implants that the Japanese tend to use. But the Japanese are masters of using cement for this. So actually, Professor Takeshi will tell us that actually, Ando people have published great results using cemented stems in the 1990s. And it seems to have, even in Japan, fallen out of favor for the use of these other implants, which for the life of me, I can't understand why we're doing. Really, I almost never use any kind of unsymmetric implants for my dysplastic hips. And really, no problem.
Bodo, can we get you on this? And especially a question on how would you deal with a deformed femur, and if you had to use a cemented stem for a dysplastic situation?
I would still use a cemented stem. Abhay, thank you very much. It's wonderful to see you all. Actually, a lot of expertise in that round. My expertise is actually only on cemented components. I've never used on some non-cemented component once. The thing actually is, even in a deformed femur, you can use components within the femoral canal. It may not, look straight within the canal, but the loading pattern makes no difference. Overall, the construct is the cement in the component that makes it. You need to choose the size of the component to fit the femur. But I think that's where cemented components make it customized from the start, especially when you have contortion in two planes. I must say I've seen some courageous x-rays today. I'm delighted to see actually how, some of you guys have cojones. I'm delighted. My expertise is not along those lines. I don't do femoral osteotomies and femoral shortening osteotomies. But the cemented component, especially when you use a small component for the femur, you can do almost anything, especially when you look at the very small people. I've got a fairly large number of patients 4 foot and shorter, or 4 foot, around about 4 foot. They tend to work well with, admittedly, customized C-stems, but cemented components all the way through. I hope I can demonstrate that in my presentation. Thanks for asking.
Bodo, can I ask you that if you have a Crow 4, would you still not be doing shortening osteotomy?
I agree with Bodo. There's really no need to do any of that. In some instances, it is right, the femur is longer, and you might have to do shortening just to match things up. But that's the only reason I do any kind of shortening. The point would be that actually, if you are going to do a proper release, and that proper release includes releasing the linear aspera. And if you do the linear aspera release, if you do a linear aspera release, then it's going to enable you to do almost anything you want to do with the femur. And you don't have to do the whole linear aspera, just the proximal end of it. Usually that's what's tight.
Just to add to that, actually, my release was actually the trichometeric osteotomy. When you look at the abductors of gluteus medius and minimus on x-rays in dysplastic hips, you often find they have a wavy pattern because they're too short for actually the anatomy. Now, they do think actually when we look at dysplasia, especially when we talk about dwarfs, for instance, they have lumbalotoses because, of course, they've got a huge tummy that needs to go somewhere. So we're looking at a complex system where the bone is too small for the organs that surround it. And I think the same happens when you look at it. Sorry, am I digressing too much?
Meenakshi, can you just...
there's some background noise.
When you take the trochanter off, you can dial the trochanter down. You typically do not need to do anything shortening on that. You get the space to come down to where you want to place the socket. I've released the hip recently, actually, with the femoral head sitting in the upper outer quadrant from a previous operation with the shelf procedure, and the head had slipped up into the upper outer quadrant. I couldn't ever bring that femur down, the hip down into the natural acetabulum, but I brought it underneath the shelf. And I think the worry that I have from all the discussions I've heard today is, one, damage to nerves and vessels, but the thing actually is for shortening osteotomies, the skeleton is not just to give us length or height, but it's also attachment points for musculature. So if you take a huge segment out of the femur, are you going to defunction the muscles onto the knee? That would be an interesting study actually to do. I would urge actually, that would be a fantastic little concept to study what the effect is of shortening bone on the femur. It doesn't affect the hip, but it sure affects the knee. That would be an interesting study.
And I would request Tanveer Sadique. He has got a wide experience of using 360-degree release of the
agree. Yes, I agree with both of them. I never do shortening osteotomy, even in Crow 4. You have seen my presentation. I never do that. And I agree that you can use the cemented small stem where there is a mismatch proximal to distal. And I got one or two cases which I will show you that you can use that cemented stem in a mismatch proximal to distal femur. I'll show in my presentation.
Okay. Abhay, can we proceed with the next presentation? It's actually of Tanveer Sadique.
Yeah, sure, sir. Please share your screen, sir. So Dr. Tanveer is going to talk to us on Pro 2 and 3 hips, issues and solutions.
Can you see my presentation?
Yes, we can see. If you can put it on full screen, please.
Is it not on full screen?
You need to just click on slideshow, the bottom right icon on your computer. Yeah, this one.
That's good. Excellent.
Fine. Basically, really, I wasn't sure where to start with, but looking on the classifications we have been discussing, I quickly will show a slightly different way of classifying all these cases. Yes, these Crow and the Harticophilatus, these are most commonly used classifications. But if you summarize both of them, you will see that you have got type 1, 2, and 3. The type 1 is where the head is contained, type 2 where it is partially contained, and type 3 where it is either dislocated or there is a false plus minus false acetabulum. And but none of these classifications take account of the femur. And so often there are so many deformities in the femur which are not taken into any of these classifications. You can have the deformed femoral head, you can have deformed femoral neck, you can have deformity at the proximal femur. There might be a mismatch as we were just discussing, but none of this is into any of these classifications. And then you can see all these cases had 1, 2, or even sometimes 3 operations. And every operation makes the revision operation difficult because of the scarring of the tissues and all that sort of thing. And again, none of these classifications take into account any of the previous operations which has been performed. And again, like this femur, the head is well contained, but can you see how the femur is? So if you really classify this according to Crow or Harticophilatus, it's type 1. Maybe we can say, looking on bilateral view X-ray, that it may be type 2, but it is basically Crow's type 1. But if you look the proximal femur, nobody has accounted that into the complexity of this operation. Therefore, we devised new classification where you have the acetabulum, A1 where is contained, A2 which is partially contained, A3 which is completely out. And the femur, either there is a single level deformity, 2-level deformity, that is head and neck, or 3-level deformity, head, neck, and the proximal femur. And then you combine with that number of previous operations. And that gives you a DDH score. That's what we call it, a DDH score. That you have got, say, acetabulum type 3 and femur type 2. So that's 5 plus 1 previous operation. That gives you 6. So the DDH score is 6. And in our study, we believe that DDH score predicts realistic prognosis and outcome after THA. Anyhow, that is basically just really after seeing all the classifications and everything, I have gone quickly through the DDH score, which we use in our studies. And now I'll come back on to the type 2 and 3. Pre-op consideration in all these cases is leg length discrepancy, as we have already discussed, relocation of the hip center, appropriate sequential release of soft tissue leading to 360 release. This is again a topic really which has been briefly touched, that if you can do a 360 release, you do not need to do a shortening osteotomy and you can still reduce the hip very well. And then predicting the need for shortening osteotomy, very, very rarely. In fact, I remember only doing once, achieving primary stability. And nowadays, I do use dual mobility cup in a couple of cases where I feel that I need a little bit more stability. Again, I think all this has been already discussed, so I will leave that. Leave that one again. 360 release, if you want to know, this is how I do. I create 2 flaps, one anterior and one posterior flap. Anterior flap contains gluteus medius, minimus, vastus medialis, and Z-plastio psoas tendon and adductor tenotomy. And then you have to do the piriformis tenotomy, and then posterior flap is posterior half of the gluteus medius, minimus, piriformis, short rotators, and deep tendon of gluteus maximus. That's my posterior. And then you can easily reduce without doing a shortening osteotomy. This is what I call 360 release. And now quickly going to the type 2 and 3 crows. And this is again a case. This is a lady. She came at the age of, I think, 21. And she had a couple of operations on both hips before. And as according to my DDH score, this falls acetabulum 2, femur 3, and plus 2 previous operations. So it gives a DDH score 7. And this is how I did the right side first and the left side later on. On the left side, if you can see the greater trochanter, basically this is completely rotated. So it doesn't make any difference as long as you do not do any disturbance with the abductors. If the abductors are there and you leave them well alone, she will do very well. And she's got excellent gait. And since then, she has delivered twice. And she is a very happy lady with a normal gait and 2 babies since she had these 2 hips done at the age of 21. I think it's almost 21 years follow-up now on this in these 2 hips. This is the hip which I was just talking, that if you see this one and see the mismatch of the proximal and distal femur, here I would invite all the faculty, what would they do for the femur? Acetabulum is easy. Can somebody?
Can I request Dr. Takeshi to come in on this, please?
For the femur, I would like the faculty to discuss.
Really it depends on the shape. I will analyze with a CT scan. The plan if the normal the stem is possible to insert. Otherwise, I'll do the subtrochanteric. I mean, it's just the osteotomy under the rest trochanter.
Anybody else?
Have to plan.
Could do a custom hip. Sorry, it's Tahir Khan. I think custom hip would be a great idea here. If you can do a custom planned hip, you can do the 3D planning using a lot of commercial or standard implants, but I think that's what you need.
Well, essentially, we have no money from where we come from. And considering where they have no money, what I would actually do is to actually just look at the leg length and either do a trochoteric osteotomy again, or do a subtrochoteric osteotomy, or just do a trochoteric osteotomy and then just slide it and reattach it appropriately.
The canal. I think the problem here is that the proximal femoral canal is pointing at about 40 degrees medial to the distal femoral canal. So unless you undo that femoral osteotomy and replace the trochanter, doing a three-dimensional...
You need to do some kind of trochoteric osteotomy, without doubt, yeah? But actually there is a straight shot down that femur from the top.
Okay, fine. Okay, that's what I did really. It's a cemented small stem and achieve the leg length as well without doing any osteotomy or anything. So who else would do that?
So we'll take Bodo's opinion on it once you finish the case, because we still 4 presentations to finish.
Okay,
so
I just wanted to be interactive in this one. Okay, fine. So just quickly, really, in our series, we had 79 patients, and what we thought that the DDH score with 3 and 4 outcome was like any primary hip replacement. DDH score 5 to 6, Trendelenburg gait and limp remained for up to 2 years, and they required extensive physiotherapy to build up their abductors. And after about 2 years, they came out of this Trendelenburg gait. But DDH score 7 and 8, limp remains permanent. And this is where, if you can see that the patient has got a DDH score of 7 or 8, you can counsel them preoperatively that they will have the limp permanently. In our series, we have a neuropraxia in 2 cases, which fully recovered. And we had to revise 1 cup after 10 years. And we had a 1 superficial infection, which was rectified by negative pressure dressing and systemic antibiotics. And this was the score, really. Take-home message is always, even if it is close 2 or 3, it's a challenging case for the hip surgeon. Demands careful thinking and planning. You have to have a plan A, B, and C. Again, for that case I shown, I had a plan in mind that I may have to do the osteotomy, but I got away with this small cemented stem. Always use familiar approach, familiar surgical technique, and familiar implant. That's the take-home message. Thank you.
Thank you very much, sir. And while we are collecting questions, maybe quickly go through the last case presentation on the series. And may I request Dr. Takeshi to come in on with his case, please?
Let me put my presentation. Dr. Tanveer, can you stop your presenter?
Dr. Tanveer, sir, you need to unshare your screen, sir.
Oh, okay.
Can you see?
Yes.
Yes, sir.
Yes,
okay.
we can see.
So my talk is about the THA after shunt osteotomy with valgus lower limb alignment. This is a patient, 66-year-old female. She had a right shunt osteotomy in childhood, and she has a severe pain and very limited motion of the right hip. This is 3D. And she also had a bilateral knee, and both were symptomatic. And right knee was valgus, and left knee was varus. And the femoral tibia angle of the right side is 152, and she also had the scoliosis. The highly dislocated hip is especially claw 4. When the patient is asymptomatic, we don't do surgery, but the THA is necessary for the cases with symptomatic when the head is contacting the ilium and there is a severe degenerative change, and also symptomatic after shunt osteotomy. For these cases, cup should be placed in the original acetabulum, and the acetabulum is small to accept cup. And subtrochanteric shortening osteotomy is necessary, not just for shortening, but deloadate the deformity and bring the greater trochanter to the lateral side. But the complications of femoral fracture, dislocation, non-union, and subtrochanteric after subtrochanteric shortening osteotomy, and possibility of sciatic nerve palsy when you elongate the leg more than 35 millimeters. There are several ways to treat this deformity, and the purpose of subtrochanteric shortening osteotomy is locate a cup in the original acetabulum and relieve nerve tension by femoral shortening and dilatation to restore the lever arm of the greater trochanter. And there are several ways to do this subtrochanteric shortening osteotomy, but I usually do the transverse osteotomy because the dissection is minimal and the procedure is very simple, and it's very to restore the rotation. And I made this device to do this osteotomy. And if there is no deformity of the femoral shaft, we insert this into a medullary rod and attach this device and fix this slotted instrument and do the osteotomy through this slot. And usually the osteotomy is just distal to this S-LOM sleeve. And this device is fixed to the bone on the planned the osteotomy place. Then after that, the trial reduction, we can measure the length of the osteotomy, the shortening osteotomy. But for this shunt osteotomy, I first do the transverse osteotomy to the proximal side and then cut the distal part. And then after trial reduction, we can pull the leg and measure the overlapping length of the bone, and then we can resect it. After that, we insert this device again and do a perpendicular osteotomy. And I always use S-LOM because it gives much better stability for the metaphyseal and diaphyseal part. And this transverse osteotomy, soft tissue dissection is kept minimal, and periosteal elevation is limited to the osteotomy site, and osteotomy was slightly distal to the sleeve. And this device, you can easily cut this distal part of the bone, and this part is fixed to the bone with a pin, and the pin is always inserted in the bone that will be resected. This is intraoperative view. And then we do a prophylactic wiring of the proximal part to prevent fracture. And after that, because of the osteotomy is perpendicular to the femoral shaft, we had a very good contact of the osteotomy site, as you can see here. And then I always put a locking plate with monocortical screws that not touching the shaft, and use the femoral head as a bone graft. And after that, the soft tissue is covered. The reason why I use the plate is that there is high tension of the lateral side of the bone because of the offset of the femoral head. But this supplementary plate can reduce tensile force and resist against rotation. And also, by this transverse osteotomy, we can preserve the blood supply to this osteotomy area. As you can see, this is another case. After just 3 months, there's a very good bone union on the right side. And this is the direct bone union. If you can see this slide, left-hand side is the case with a locking plate, and you can see that direct bone healing here, but without a locking plate, usually the healing is indirect bone healing. And this case was done with this procedure, and after that, the varus deformity is slightly improved, but still the mechanical is far on the lateral side. For this deformity, we have to correct the mechanical axis. To correct that, I did a distal femoral closing of biplanar osteotomy. The advantage of this biplanar osteotomy is the stability against rotation and early rehabilitation, and distal bone cut is very wide, and there is a very fast bone union, and the rehabilitation, that's fast in the rehabilitation. And we can preserve the suprapatellar fat pad that will help for the knee motion. The preoperative planning is that this is the mechanical axis now, but the planned mechanical axis here. So for the planning, extend the midway canal, and we need to bring the femoral head from here to here. And the osteotomy hinge is here, then we have to bring this head to here. This is a correction angle. And we should create the same angle in the distal part. And after that, closing with this wedge, we will have this correction. And this is the actual surgery. And after this, we can obtain a good mechanical axis, as you can see here. And this is 5 years after. There is a good union, and the very good alignment is preserved, and the score is getting better. Take-home message of this case is acetabular cup placement in original acetabulum in total hip arthroplasty for claw 4 and subtrochanteric transverse osteotomy with additional plate combined with slump stem is advantageous for early and sound bone union. After shunt osteotomy, valgus knee is often associated with. Only THA doesn't solve the patient's symptoms. Lower extremity alignment should be considered. Medial closing wedge by biplanar distal femoral osteotomy solve valgus knee. Thank you for your attention. Thank you.
Thank you very much, Dr. Takeshi. That was a brilliant case. And may I just open this case to the House and for the opinion of the faculty? And may I start with Dr. Mojieb and Dr. Vijay, please? Would you do this any differently? Dr. Mojieb, sir.
I usually put, well, two things here, and I thank you very much, Dr. Takeshi. Wonderful presentation. So one thing I wanted to comment is that in claw 4, as the femur is sitting, above the acetabulum and bring it down, automatically you're restoring the horizontal offset, and you're adding a little bit of a valgus angle, or you're restoring the normal head neck shaft angle, which means that a lot of these patients, let's say 6 months down the road, when they're happy, they have healed, you do a hip to ankle x-rays, and you do find that they now have gotten a valgus mechanical axis. So I think they should be on the radar that at some time down the road, they do need a distal femoral varus osteotomy. I think depending on their age, obviously you don't want them to become fully arthritic, but if they are old enough that they're getting close to when they will need a total knee, you might save that to do a total knee and correct the valgus at that time. In terms of fixation, in the beginning of my career, maybe I was too aggressive. I did put the unicortical DCPs. I just felt that I was having more bulky, maybe because our patients are too small, and I backed out and I used the circulage, but I don't use a regular. I use the tension cable. So I have a tensioning device. I make sure that I really pack that osteotomy gap with abundant autograft, and I make sure that my strut is vascularized. And again, I don't use Esrom. I use the Wagner. So that stem size that I use is really, I go up as tight as I can. So the distal fragment and the distal part of the cone stem is very solidly opposed and holding the distal fragment very well. So far, I didn't have any non-union with the circulage. Neither I had them with the plate. I just felt that with the plate, patients were complaining of some pain and kind of like a impinging hardware. So I don't know the right wrong answer.
Yeah, but this plate is a very small. There's 3.5 cortical screws, the rocking plate. So it doesn't harm or cause symptoms because there is small thin plate.
Can I have
if you use a non-locking plate, you need to use a larger one. But if you use a locking plate, you don't need to use larger ones.
But this is a classical example of a situation where your osteotomy may be a little more distal than your sleeve in cases where you have a non-modeled Schanz osteotomy. And another reason is once you've done your reaming, you might need to increase or upsize your SROM by one size very often because it comes loose. So we have Dr. Rajesh Malhotra sir, we have with us, and Vijay is probably got disconnected. May I request sir for his opinion on this case and certain very important take-homes for situations where you have a proximal femur deformity, sir?
Yeah, thank you, Abhay. Thank you, Dr. Shahid. It's a great event, and I really enjoyed every minute of it. What Dr. Takeshi showed is classical way to manage it, and in the subsequent talk, which is by Krishna Kiran, will show that this is classically the type where you have to take out bone from proximal as well as distal fragment when you do the subtrochanteric osteotomy. So I think what he showed was perfect, and I also agree with him that on the concave side, the tensile stresses are going to be too high in a case like that, and they may be a good reason to put in a narrow locking DCP there. My only take on this is that many times, if you do a distal femoral osteotomy, corrective osteotomy in time after skeletal maturity, you can actually avoid osteoarthritis in the distal in the knee joint. In fact, we have seen some of the early to moderate osteoarthritis reverse after a distal femoral osteotomy. So that's something I would have liked to say in addition, that a timely distal femoral osteotomy can actually prevent osteoarthritis or even reverse it to some extent. But it's a very well done case, Dr. Takeshi. I congratulate you for that.
Yeah, this patient didn't need a total knee on the right side, but the left side she needed a total knee. But because of the varus femoral deformity, I did a trochanteric valgus osteotomy to avoid the problem of the total knee.
Yeah.
Dr. Takeshi, if you apply strut on the lateral side, would that give you the same mechanical protection against the tensile forces that you'll get by a plate?
No, I don't think so, because for the resistance against rotation, the plate is much better than the strut graft. The bending,
although you're putting two, like you're putting strut, which is kind of wraparound. So you're putting one on the lateral side and one either anterior or medial.
But it's not easy to resist against rotation.
Okay.
Can I, before his talk on the complications, can I quickly have Bodo onto this one? Would you do anything differently, Mr. Purbach? You're a pure cemented guy. So would you deal with these proximal femur deformities any differently, especially the case that is shown by Dr. Sawaguchi?
Can you unmute yourself, Bodo?
Bodo, you're muted. You need to unmute yourself.
Can you hear me?
Yes, you can.
I'm impressed, actually. That was a good solution to that case. I think, actually, in that case, you would have to ask, I would have to ask one of my colleagues to do an osteotomy and use a non-cemented component. I am a fully cemented guy. I have no other experience. And I think, actually, I've heard that before. One of the great things this morning, actually, was I hear everyone say things that I say I can subscribe to. Absolutely. You know, stay with a familiar technique, stay within the realm of what you can do. Something like this probably would need an osteotomy. The case beforehand, I would have done the trochanteric osteotomy, but you can see actually how we vary in practice, and you stay yet consistent in our own practice. This probably would have had to have an osteotomy, and I would have asked one of my colleagues to take that on. I would normally warn about wrapping around too much bone around femoral osteotomies. Fractures want to heal because they want to heal. Mother Nature does that. The less we do, the less we interfere, the better it is. You can see the discussion we have, how many strut grafts you have to have and how many plates you have to have. Less is more. Leave Mother Nature to heal. Less periosteal stripping, less wrapping around, less constraining. Cables don't do well in my view. I've never used cables. Chinese compression and the wiring technique has its own problem, admittedly, because of course the wire can break and rip because you got that. But the cable wants to be flexible right from the start. which is counterproductive what we want to achieve, stability. So either plating or wiring. I wouldn't necessarily go to cabling. I've got bad experiences from cables that I've seen done. And by the time you give stability, Mother Nature wants to heal. It's not us. It's not what we put in. Fractures heal because Mother Nature wants to.
Great points there. Bodo, can I just request you for your talk now on complications, the surgeon's nightmare? And I believe you have a variation to this program, which is
if
perfect.
That's okay. And a second. I need to share screen. That's the one. Can you see me all?
Yeah, yes, we can.
Yes, we can.
Slideshow, start from the first slide. I've taken liberty. I've seen fantastic stuff this morning. I'm impressed. Actually, there's a huge amount of expertise in that small group of surgeons this morning, and everyone has a fantastic standard of how to do with things. Dysplastic hips are, of course, only a subset of complex hips. And my lecture is almost summing up my experience as a surgeon at Wrightington. I am the Charney guy. I still do Charney hips, and I will go out doing Charney hips. The Charney Institute, of course, is more or less the inheritance I have from my teacher, Wroblewski. Mike Wroblewski is the guy that took over from John Charney. I'm the third generation. Unfortunately, the Charney hip will go out with me. By the summer, I will finish as a surgeon. That means actually no Charney hips will be done anymore at Wrightington. Peter Kay, he was one of the early fellows with Mike Wroblewski, and I was one of the late fellows. And Paul Siney. I had to bring this picture up. That was when I was a young man. Mike Wroblewski is an outstanding and probably the most important hip surgeon of the last century. Pat Fleming was our audit officer. She made sure that the data were collected, and Paul Siney is the man that makes my presentations look good. The reason why I've had to show you that picture is actually because, of course, that's the same entrance, Abhay, you may well remember, you walk through when you come to Wrightington. John Charney in the 70s, 40 years later, this operation still means something. Complexity, of course, is the thing when we can't quite isolate the things that smack us in the face. And it's too overwhelming. It's the large number of closely related parts that interfere with what we normally do. Alignment, dimensions, coverage, previous surgery. And of course, complexity actually doesn't really make it difficult. What we need to do, actually, we need to reduce that to the single problems that we have to face and break it up into manageable portions. So start from the start. Look, you can see this is one of the cartoons we have on the wall at Wrightington. It is overwhelming. The stuff we do is overwhelming. So you break it up into single steps, you line it up into the numbers 1 to 100, and you get through that, and then you get to the solution. Scars, puckering of skin, previous infection, hardware, and then you can stage it as well. I've heard that already as a comment this morning. When implants have been in for such a long time, they make up cortex. By the time you remove it, there is no cortex. Do it in 2 stages. Don't hesitate. We all have the discussion about 2 stages for deep infection. I think this type of revision work can also be done in 2 stages. By the time you go back in 6 months later, he's got a cortex. Pack into it, and it suddenly becomes a normal primary hip replacement. Metalwork on the inside. The approach to the femoral canal is through the piriform fossa. The easiest way to do is take the trochanter off. 1, you do not damage muscles. 2, you do not take muscle off bone. You reattach bone, and it allows you to see perfectly well what you need to remove, then remove carefully, and you get in it to do a hip that looks normal, standard stuff. You can see that puncture nail. I had the AO fellows at the time who said, actually, why don't you do a retrograde extraction through the knee? Well, it was introduced to the piriform fossa. This man has a below-knee amputation. There's, of course, no choice to go through the knee. But the thing actually is, by the time you expose the trochanter, you can do everything, both for the acetabulum and the femur. And it becomes an easy operation. To slip that nail out took 5 seconds, 10 seconds. Not a big deal when your approaches are right to show you where you need to be. Again, on the same day that at this case, a colleague of mine actually went into the other theater with a similar thing, tried to remove the nail from the outside, struggling hard. Do it the other way around. Dislocate the hip, take the neck off, punch it through retrograde. Fairly small procedure, and actually it's part of the course to get into it. This patient told me he needed to have it for his model railway. You can see it on a narrowboat. He wanted to have something to say, actually, I've lived with this for 50 years. It needs to live with me for further. Well, for metalwork in the femur, you don't need a huge amount of particularly specified instruments. We've got a fishtail screwdriver, which is basically just a shaped up screwdriver to break the nail within the femoral canal. And the rest is stuff that we have anyway. The key to Charney's operation is, of course, go through the trochanter. It allows you both access to the femoral canal and to the acetabulum. We've talked about, and we've seen enough dysplastic acetabula. Of course, coverage, you need to get orientation, you need to get center of rotation and leg length becomes secondary to all of the other things. And I always worry when I hear about subtrichotic shortening, these legs are short to start off with, and then we shorten them further. When you take the trochanter off, it typically is no problem to bring the femur down under. And I have yet to encounter a problem either with the femoral nerve or the sciatic nerve. You can see actually bone grafting is the stuff that's in front of you, that's available to you. And it doesn't need anything specific. This business about trabecular metal or augments and stuff, this is restoring what's needed. And you can see the size of the component remains the same. You haven't lost anything. And even if part of the bone graft fails later, you'll find that part of the bone graft still stays in there and makes the next operation easier to cope with. You can see that on the left side, on the right side. Small grafts are harder to do than large grafts, but they typically have a higher success rate. Identify the anatomy that is bringing it down to the teardrop, absolutely so. Yes, dysplastic hips typically have small anterior and posterior dimensions. You can see the problem of using power tools. They remount anterior and posterior. We don't even think about it hard. The superior rim is the bit that you can reconstitute quite well with bone grafting. But of course, bone graft typically goes well with a cemented component. I can't quite imagine how well they go with a non-cemented component. Bill Harris's study from the 1990s, as often as he quoted, I think is a misrepresentation of technique. Don't forget, he stripped both the inside and the outside and bolted bone graft through it. That is massive damage to soft tissues. And Bill Harris only demonstrated in that paper, with this technique, you cannot do it. But it does not mean that bone grafting doesn't work. You can see that's a high-riding dysplastic hip, and it still does the job. This is a 38 socket. This is where Shani's operation really works well. One, the trochanters come down beautifully well. Two, smallest of components. Three, possible to do. You can see you can even revise 38 sockets. This is a 38 socket, and as the primary goes, the revision was probably easier to do, because, of course, without hard sclerotic floor, cement wouldn't last particularly well. But if you do it quite smartly, you can get a 38 socket revised in a small cavity that she presented with. Bone grafting, expose the sclerotic bone, create the shape to match it. It's almost like 3D printing in reverse. And then you use one slot for a screw to put it through. That's my criticism of Bill Harris's paper. It's not much point stripping and bolting. This is too much hardware. Try to stay small. Try to do small things from the inside of the acetabulum out, and lag for compression like you would do for fractures. Difficult femur. We've seen fantastically converted necks and femoral heads from previous surgery, small dimensions. A distorted femur does not necessarily always need to be corrected, and I'll show you a couple of cases. Of course, that straight stem in a contorted femur isn't going to sit straight, but it doesn't distract from the function of it. One, you can see actually the acetabular defect covered nicely. And two, even if the femur is curved, the component in it doesn't need to be curved to match it. And it's a deformity in two planes. That's the lateral front to go with it. How to address the femur, find the entry point into the femoral canal. And of course, that is, to me, through the feriform fossa. And all the surgeons that have introduced nails into the femur will know that. Check reversion and alignment. I tend to try and stay neutral, both for the acetabulum and for the femur. That is easier to see. 0 degrees is something better than we can match than anything like 10 or 15 degrees. And you can see that's the piriform fossa before the ridge is taken. The outside to the left, where the leg holder actually has the femoral lever in, that's the outside of the femur. And you can see the version or the position of the femoral neck as an entrance. That is straight up and down. And you can see 90 degrees to that makes it a neutral alignment of the femur. If you don't get the approach right, that's the anterior approach. That's what we used to see round about until the 2000s when surgeons used to use an anterior approach. That's an easy one to rectify once you take the trochanter out. And the patient was happy enough to come back to have the other side done. Custom made in small patients, yes, I have done that too. But we used to have the C-stem, that's off the market, I'm afraid now. With the Asian size range, actually that was good enough to allow even in small hips like these with previous fractures or deformities to do it. The left hip, by the way, that's a post-operative fracture. And the reason why I've left that x-ray, and you can see the sockets are 38 sockets. The reason why I've left the x-ray in, she fell mobilizing day 2 from surgery. And before you rip everything apart, leave her alone. She was in bed for 4 weeks. The fracture had started healing and she started mobilizing 4 weeks later. We tend to forget simple solutions. We try to over-engineer things. We're trying a lot of metal work to throw in. Not always the best idea. She has done well until she finds... You can see, even though this hip is actually askew with at an angle, actually, she had functioned right to the end of her life with that deformity. Templating and planning, 3D and all that stuff becomes difficult for me. I've seen fantastic 3D models. The worry that I have is that we're distracting mentally ourselves. It's almost this thing actually that you only look at bone. And then suddenly in theater, we get flustered because there is muscle attached to it. The soft tissue mantle changes what we're looking at, but also you got to worry about the nerves that attach to the thing. You can see it's the same patient. On the one hip, he's got an adduction deformity. On the other hip, he's got an abduction deformity. So it's almost, to me, actually, intellectually, it's too much challenge at the time. Stay with a familiar technique, with your familiar approach, and try and make it look normal. And you can see suddenly the left hip sticks out like a sore thumb with the abduction deformity, but he's only got a normal chan hip on both hips. Determine the anatomy by all means. The size of the prosthesis and cemented components is your choice. You can always reduce the size for cemented components. Prepare a bone bed. That's where I come in for bone grafting. This is my big take these days. Use bone graft. This is actually really the stuff that's often missing and that's going missing when you replace joints. Rehearse positioning, and then you just go with your technique, with your approach. And this is basically what I think it's a routine surgical technique for the variation that the patient brings. And it does allow for most anatomical variations. And I almost dare say, actually, if you can't do it with cemented components, it's probably worth thinking about whether it really needs doing. Cemented components will allow you to do that with conservative approach. And of course, you can revise it and you can put it back together. But the key, and I've seen that before, that was a fantastic comment, routine technique, stay with what you normally know. Just to show you a couple of run-through things. This is a customized component on the left hip from 1992. The right hip, I've done that in 2000. And you can see these are super small components customized to the patient. He ended up with a psoas abscess that was draining through the hip. And even though there was pus pouring past the hip itself wasn't infected. So I only cleaned him out, left him alone. And he continued to function with that to the end of his days. And you can see that that's the last x-ray we have of him before he passed away. Again, metalwork on the inside, this plastic hip on the other side, you don't have to worry about it. It's not even in no consideration to have to tackle it. We don't have to touch everything that looks at us. And you can see that's at the end of it, 2021, the last x-ray you have from her. Again, customized components. These are toothpicks. These are 22 millimeter bearings. Don't just to get the perspective of what the patient presents. There are 4 foot tall patients, 38 sockets, 22 millimeter bearings, 7/8 of an inch. They're customized. They're about 5 to 6 centimeters long. And you can see actually they are tiny in dimensions. She breaks. Can you see that on the left hip? And you suddenly have to worry about how do you get in, how do you remove components, how do you fix the next component, how far can you go distal? You can't really, unless you take the trochanter off. This is the CDH stem that I've used for revision and bone grafting. And this is the last x-ray I have to show up from her. And this is pretty much my presentation today. unshare. Stop share.
Thank you so much, Bodo. Amazing presentation, as always. You stand out as you stand out as a lone fighter in a world full of hardware. So I have a couple of questions before we go on to something which is evolving and a work done by Krishna with Dr. Malhotra and Dr. Neeraj. And the questions are, how do you decide between an S-ROM and versus a cone Wagner? So may I just request Dr. Gokhan, your take on this? You've just done a talk on femur stems. So how do you decide between choosing an S-ROM versus a cone Wagner for a high dislocation hip?
Actually, I have no experience with S-ROM stem. We don't have it in Turkey. I don't use it. The only stems that we use in here is like the Zweimüller type stems and Wagner cone stems.
May I request Dr. Tanveer for his opinion on this one? You're muted, sir.
I said I use standard stem. I don't use the modular stem in any of my cases.
Dr. Malhotra, sir, how do you decide whether you would use an S-ROM or versus a cone Wagner, sir?
So, Abhay, if there is considerable metaphyseal diaphyseal mismatch, you are better off using an S-ROM stem. Otherwise, the versatility in terms of adjusting the rotation or sinking it is equally good with the Wagner cone. But I think the point where the S-ROM scores is, to my mind, two things. One is like I said, the metaphyseal diaphyseal mismatch. And second is that versatility of the S-ROM stem to adjust limb length at 3 places, by sinking the sleeve or leaving it proud, by adjusting the neck length, and by adjusting the head. So that way, equalization of limb length can be much better with S-ROM as compared to Wagner, where you'll have to really sink it in to make it shorter, but there's no way you can make it longer. Only that you can do only by adjusting the neck length on the head.
Thank you so much, sir. And another question is, what is your preference on the cup side? And may I request Dr. Takeshi to come in on this? So how do you choose which cup you will use, and how do you define and decide your preference on the cup side?
It depends on the cup size and on also the quality of the bone of the acetabulum. If the quality of the bone is good and the size is larger than 40, I will use the non-cemented cup. But the size is less than 30, 40, for instance, 38, and the quality of the bone is poor, then I put the femoral head as a bone graft to pack in the acetabulum and use a cemented cup to keep the thickness of the polyethylene.
Okay, thank you so much, sir. Dr. Mojieb, so would you differ, or would you decide differently, or would you do anything different here?
So on the cup side, I'm a cementless guy. As a matter of fact, I've debated with Dr. Chun about cementless versus cemented. So on the cup side, I prefer to use the ultra porous, the TM or the ultra porous devices. Gives me very good fixation, and it does allow you to keep up to 40% of the cup uncovered. So if you had to put a cup and for whatever reason you couldn't put a structural autograft, you could not put an augment, then you can leave the cup 40% uncovered and put your appropriate version and lateral opening with a cementless cup. And then of course the poly will be one of those higher cross-linked, or I'm not a ceramic liner user, but I do use ceramic head. My only problem with this is that I'm restricted with the 32 not starting below 48 and the 28 not starting below 44. So the size of the cup will determine the size of the head, which I think is the same thing even if you use a cemented cup. And I think the survivorship of the cemented will be less than the cementless. So, and these patients are by default relatively younger or comparatively younger than the traditional patients who get a total hip.
Thank you so much.
And I have one more comment, if you allow me, about the modular hip. And maybe Dr. Malhotra can join in as well, is that the difference between the SROM and the non-SROM modular systems like the ZMR crossover, the Arcos restoration, those do not have an empty sleeve through which you can put a stem. So those have a very kind of monoblock neck and a sleeve, or a metaphyseal fragment, that you cannot have an independent rotation of the neck on the sleeve. That's the one advantage of the SROM. But the SROM distal part is more of a fill rather than a fix, whereas the other modular system have a distal fragment, which could be conical or tapered, as well as an anterior beveled edge, so it will prevent any perforation. And that's something you need to keep in your mind if you're using one of those modular systems, because these patients are short. You have already shortened the femur by about 3 centimeters, and your distal fragment, if you're going to use a modular system, you got to put that trial and make sure you're doing them with a C-arm taken through the lateral projection to make sure that your stem, or the tip of the stem, does not perforate anteriorly.
Great
That's
point,
one thing that can very, very well happen. There are certain designs that do have the taper is beveled, and that bevel needs to be dialed in to face anteriorly.
Thank you so much, sir. Great point, sir. Dr. Malhotra, sir, your take on the preference on the cup side before we go to the last question and the last topic.
Like it was said, the choice depends on the size. We have small size socket. So first thing is whatever is available. So more often than not, we end up putting the pinnacle cup, or the Gription pinnacle, which is the cup which is available for small size with us. But then, given a choice, like Mojieb said, I would like a ultra porous cup, the surface, the model porous coated cups, any of those with the porous coatings. I would want a multi-hole cup, because more often than not, we do end up putting a screw in pubis or a screw in the ischium, or both. And that actually really gives me a very good comfort level, that I know that my cup is really very solid. So those are the options: multi-hole, hemispherical if possible, porous coated. Those are my choices, and available in the small size.
Thank you so much, sir. And the last question is, how do you deal with a hip which has a trochanteric overgrowth, before we go on to the last talk? Dr. Mansoor, sir, can we have a take on it? How do you deal with a dysplastic hip which has trochanteric overgrowth?
This is for me, right? Yeah. Trochanteric overgrowth, we have done trochanteric osteotomies and shifted it down, in which just the tip of the trochanter is a bit high, and I sometimes release the abductors from all around it and just trim the tip of the trochanter.
Okay, Dr. Takeshi, one quick answer before we go on to the last talk.
I usually use cemented stem for up to claw 3. So if you use a curved stem, you don't need to do a trochanteric osteotomy, but the trochanter hangs very much, then I need to do a trochanteric osteotomy.
Are you worried about the abductor shortening in cases where you have a trochanteric overgrowth and a high-riding hip?
Yeah, it depends on the level of the head. If you can bring the head proximal, then it doesn't matter, but you will put your head very low, then you have to compensate that weakness by bringing the trochanter to the distal.
One last comment, Dr. Malhotra, sir.
So that's a very good question. We must remember that the trochanter has to be brought down. Otherwise, you don't have enough horizontal offset. So the best thing, and you can't really leave a stem very proud, because then it becomes almost impossible to reduce it. So I think the best way, if you have a trochanteric overgrowth, is to do a subtrochanteric osteotomy, so that you can have enough horizontal offset proximally, and still you can reduce the hip back inside the acetabulum wherever it is. And so I would have very low threshold for doing a subtrochanteric osteotomy, and give the proper horizontal offset so that abductors are good and the trochanter doesn't impinge.
Thank you so much. One more point, Abhay, on top of what Dr. Malhotra said, is that if the greater trochanter overgrowth is not obscuring the canal, so if the overgrowth is not coming on the medial side, if you can have a straight shot down the canal, then you just need to shave it. The concern is that if the greater trochanter is overgrowth to a point where you do not have a direct shot to the intramedullary canal, that's when you need to do maybe a greater trochanteric osteotomy to open the canal for yourself. Apart from that, if it's a straight shot, you may just need to face the medial aspect of the GT. And Bodo is very happy about my answer because I'm not saying anything cementless. I'm walking away from metal.
So can we have the last talk, Meenakshi, on a new classification for Crofors? So that's rather than looking at the hip which has gone up, we are essentially doing a classification which is looking at how do you bring that down and the problems that one has to deal with.
While we are putting the presentation, I have a comment from Bodo that you've produced excellent result with the conventional polyethylene. With the modern polyethylene, for example, cross-linked polyethylene and vitamin E, do you think that the use of uncemented cup might be unnecessary and you can produce even a better result? And Tanveer and Bodo.
I've got to worry about the cross-linked polyethylenes. Don't, there's one thing. When I told you about Mike Wroblewski, he started using ceramic and cross-linked polyethylene in the 1980s. We got a series of hips at Wrightington. They were technically super difficult to do in the 1980s. So we got 25-year results on cross-linked polyethylene and ceramic. And the thing actually is, they were doing fantastically well. They were silane cross-linked. Now, in the 90s, we started with Hylamer. I don't know whether you're familiar with Hylamer. That stuff did fantastically well. Around about 11 years, they started flaking. Now, vitamin E, we always have the assumption it's vitamin, so therefore it's good stuff, it's new stuff, it's healthy, it sounds healthy. But actually, vitamin E is used to counteract the damaging effect of radiation. So the companies actually damage the polyethylene to cross-link it. Now, the problem is when you look at knees and how they fail, how the polyethylene in knees fails, they laminate, don't they? Because they're work hardened, they're warping. The warping effect actually creates flakes of polyethylene. Now, cross-linking does something similar. Cross-linking does very much the same thing. The intensity of the radiation beam as it goes through the plastic will link the superficial structure more than the deep structures. So you will get layers of cross-linking as you go through it. So ultimately, you may end up with cross-linking patches of polyethylene that break off similar to on knees. The thing actually is we've got data for 10 years. That's brilliant. But the polyethylene that Charlie used from the 1970s is probably better quality than the stuff we used in the 1990s. So the cross-linking at 10 to 12 years may just be good enough just about now. I have seen cross-linked modern polyethylenes wearing superbly well at 12 to 15 years. I think we're setting us up to failure. It's not uniform density or uniform cross-linking you achieve with cross-linking. And how companies apply vitamin E or whatever measure they use to counteract the damaging effect of radiation is not out. No company has disclosed the data, and we haven't got comparative data of cross-linking. We don't even look at it because we have ODAP rating at 10 years, and that's it. My hips last 20, 25 years. I look at Charney's work, I look at Wroblewski's work, I look at my own hips. They last 20 years on conventional plastic. Nobody has yet looked at cross-linked at 10 to 15 years to compare the type of cross-linking we're looking at. We're setting us up to failure. And the problem actually is when you have a non-cemented shell and plastic inside, you got a warping effect as well because the locking mechanism is not absolutely secure. The backside wear that the Americans describe is not so much backside wear, but it's movement between plastic and the metal shell. There's yet more trouble to come, gentlemen.
Thanks, Bodo.
Bodo's warning signs. I think we can go on to the last talk.
Yeah, please. Please go on.
So can we have Dr. Krishna's talk on the new classification of Croflaw?
My brief is to talk about new classification of Cro4 with implications of subtrochanteric shortening osteotomy of these classification system using the SROM implant. Now, the Cro4 has traditionally been described as having two variations based on the absence or presence of pseudo-articulation of the acetabulum. And in general, it has been suggested that the proximal femoral development is more normal in patients who have got some sort of a pseudo-articulation. In a model to use to predict whether these patients do require a subtrochanteric shortening osteotomy, it has been found that the presence of pseudo-articulation, less than 30% migration of the femoral head, previous surgery, and use of a conical sleeve could be predictors of a THR possibility without subtrochanteric shortening osteotomy in these cases. However, most of these patients are managed with anatomic socket reconstruction and some sort of a subtrochanteric osteotomy to address the pelvifemoral muscle tightness and the sciatic nerve tension to reduce this particular hip. Most of the variations of the pelvis in Crow-4 dysplasia have been described on the iliac, acetabular, and ischial side. And these are based on various lines which are drawn across the transiliac, trans-SI joint, trans-teardrop, and inter-ischial lines. And when we look at these lines which divide the development of these segments into different variations, the variations in iliac, acetabular, and ischial anatomy usually do not have any relevance to the clinical management. And it is the high-riding femur which needs to be brought into the anatomic socket, and the problems which are encountered in that particular situation which are more relevant. And you can see in this case that the proximal femoral anatomy is well developed in patient with pseudoarticulation vis-a-vis a patient where there is no pseudoarticulation. Now, we propose a classification of Crow-4 based on femoral morphology instead of acetabular parameters. We looked at the neck shaft angle, presence or absence of trochanteric overgrowth, presence of previous surgery with the possibility of a subtrochanteric deformity of either valgus or varus. We looked at the extent of proximal migration of less than 30% or more than 30%, and presence or absence of false acetabulum. The type 1 was classified as one having a near normal neck shaft angle with a normal relationship between the tip of the trochanter and the center of the femoral head. There was no trochanteric overgrowth in these cases, and most of them had got a pseudoacetabulum formation. And the migration was between 20 and 30% in most of these cases. The type 2 was the more than 145 degrees neck shaft angle. There was no trochanteric overgrowth in these cases as well. And usually the pseudoacetabulum was either present or absent, but the neck shaft angle was more valgus in these particular situations. The type 3 was the varus neck shaft angle less than 125 degrees, and some of them had neck shaft angle less than 100. And these patients had associated trochanteric overgrowth. There was incidence of proximal distal canal mismatch, with the proximal part being narrower as compared to the distal part in around 20% of these patients. And most of them did not have a pseudoacetabulum. And the proximal migration was usually more than 30% in these cases. The type 4 was the previously operated cases, either through a Shan's osteotomy or a varus derotation osteotomy, which failed to remodel. And this can be valgus or varus neck shaft angle, but with residual subtrochanteric valgus or varus deformity, which requires a bed-shaped osteotomy to correct. And the pseudoarticulation could not be present in some of these cases. We did a 3-center study from Medicover, All India Institute of Medical Sciences, and University of Pennsylvania, and looked at 52 consecutive hips with Crow-4 dysplasia in 32 patients. We found that 12 of them were categorized as type 1, 20 were type 2, 16 were type 3, and 4 post-osteotomy. There were 27 men and 25 women in these cases. The mean age was 34 years. 4 of the patients with the varus and the trochanteric overgrowth variety required an additional plate fixation for stabilizing the subtrochanteric osteotomy. There were 2 dislocations. There was 1 subtrochanteric non-union, and 48 of the patients required subtrochanteric shortening osteotomy. And we did not note any sciatic nerve pulses in the patients. Now, the treatment in the standard or the type 1 variety is anatomic socket restoration, use of the modular sleeve implant, and an osteotomy at around 1.5 to 2 centimeters distal to the sleeve, in association with a complete proximal femoral release except the abductor muscles. And usually by shortening a segment of bone, we are able to achieve reduction in these cases. Now, certain modifications needed to be made for the other varieties. For a type 2, it required a higher neck cut, and sometimes the 1.5 to 2 centimeter calculation was slightly above the level of the lesser trochanter, which led to an intertrochanteric type of osteotomy rather than a subtrochanteric osteotomy. And it also included anatomic socket reconstruction like the previous varieties. The implications: high neck osteotomy, and the transverse cut may violate the lesser trochanter, which will have less implications in type 2 because the iliopsoas is anyhow released to address the soft tissue contracture. The type 3 is the ones which have got more implications because of the presence of trochanteric overgrowth and a varus neck shaft angle. So there is an element of supratrochanteric tightening in these cases in addition to the infratrochanteric shortening. And in these cases, a low neck cut is important to sink the sleeve lower to address the supratrochanteric component, and use a neck length which has got a small neck length to address the reduction problem. Most of these patients were okay, but at least 25 to 30% had proximal to distal mismatch, where the proximal diameter was lesser than the distal diameter. And this will require the use of a derotation plate when we use an SROM type of implant. And in one of the patients, we had to do an expansion osteotomy of the proximal femur to accommodate the corresponding sleeve for that particular patient. So this is a case example where a proximal expansion was done, which was wired, and then the surgery was carried out. And these are case examples where there is a trochanteric overgrowth with a varus neck shaft angle, which required a derotation plate to address the slight rotational issue with the subtrochanteric shortening osteotomy. Coming to the last variety, which is the previously operated cases where there is an angular deformity in the subtrochanteric area. This is a case of subtrochanteric shortening osteotomy secondary to a subtrochanteric procedure, which was done like a Shan's osteotomy or a pelvic support osteotomy. And these are usually accompanied by a varising distal femoral osteotomy with leg lengthening. So these patients do not have leg lengthening. So this must be discussed with the patient, as some of them may have residual over lengthening if the varus component was over lengthened. And in these cases, instead of doing the sleeve and doing an osteotomy 2 centimeter distal to the sleeve, the osteotomy will have to be primarily performed at the level of angulation, wherever that is, and then do the anatomic socket reconstruction, sleeve preparation, and shortening both from the proximal and distal fragments, usually in an angular fashion with to correct the angular deformity. So the implications of type 4 are that osteotomy may have to be at the level of angulation, and shortening both from proximal and distal fragments as required must be done in these cases. And that's the postoperative X-ray and follow-up showing good union of the subtrochanteric osteotomy. Finally, coming to the previously varus derotation osteotomized hips with a residual varus in the subtrochanteric area. If you notice here, once we position the modular sleeve, the distal part is angulated, and it may require some sort of a lateral opening, closing wedge osteotomy in order to make sure that the distal fragment can be entered in a safe manner. And this is a sort of modification we will have to make with the subtrochanteric shortening osteotomy in patients where there is a residual varus angulation in the subtrochanteric area. And that's the postoperative X-ray showing anatomic socket reconstruction and subtrochanteric osteotomy, which has been stabilized. So to summarize, identifying the different morphologic patterns of the proximal femur with the presence or absence of the pseudoacetabulum allows us to decide what type of STSO technique using SROM can be used. In type 1, usually a standard STSO technique can be employed. In type 2 cases, one must remember that the neck cut must be higher to address the valgus neck, and sometimes the osteotomy may have to go through the lesser trochanter instead of the subtrochanteric area. In type 3, where there is a varus with trochanteric overgrowth, a combination of sinking the sleeve low and STSO is done, and we must consider a derotation plate in patients with proximal distal mismatch, and occasionally a proximal expansion osteotomy where the mismatch is more. In type 4, the osteotomy at the level of valgus or varus subtrochanteric angulation is done instead of the standard 2 centimeter distal to the sleeve, and shortening in a wedge-shaped fashion appropriately from the proximal and distal fragments must be done to achieve the correction. Thank you very much.
Thank you so much, Krishna. And we have Krishna with us online. So Krishna, can you just quickly talk us through the philosophy, and can you just discuss the philosophy with the faculty? I'm sure there are going to be questions on it.
I think the philosophy was based on our own findings, which we found in a lot of cases. And not all patients were similar. So typically the Crow 4 or dysplasia patients have got valgus neck shaft angle with a narrow anteverted canal. But that can be modified based on whether these patients have been intervened upon with a open reduction when they were younger, or some sort of a pelvic support osteotomy which has been done, or whether there is a pseudoacetabulum formation based on the anatomy of the proximal femur was variable. So this led us to look at cases. So I personally had around 18 or 20 cases with me, and so I requested Professor Malhotra, my teacher and boss, and I actually ran this concept across him, and he said he also found similar sort of a morphological variation which needed some sort of a thing. So it was more of a retrospective analysis of our own cases, and we actually have more cases than which we could collect for this particular presentation. So we have nearly 70 to 75 hips, but we have not analyzed all the x-rays. But around 52 hips we were able to analyze from 3 centers. And these were the 4 major patterns we found: that normal pattern, the valgus pattern, the previously operated ones, and the varus with trochanteric overgrowth. And the varus with trochanteric overgrowth was the one with maximum implication, because these could not be stabilized just with an SROM alone because of the mismatch between the proximal and distal fragment occurring in 20 to 30% of these patients, and required additional modifications with respect to how we position the sleeve and then use the plate if required.
Thank you so much. And if there are questions from the house, we can take some questions for Krishna if there are from the faculty. And before we wrap up for today's event, Dr. Takeshi, Dr. Mojieb, sir.
So this classification is very much for CRO4, but it's very much SROM dependent. So if you're not using SROM, how would be the implication? See, I don't use SROM, so how would that help me in choosing different management options?
The level of osteotomy would still be, similar. If you had a previously operated case and the angular correction, then where you would do the osteotomy would change. And there are people who do distal osteotomy as well. But I think by and large, the standard of care is with the use of a modular implant. So that is why I thought it is important.
Do you think there's an opportunity for this classification to be either modified or still done in a way where it's more universal, regardless of what implant you're using? Rather than linking it to the SROM or linking into a modular, we can do like a subtype classification of CRO type 4 based on, subclassified to type 1, 2, 3, just like you did, in a way that it's not it doesn't imply usage of SROM or usage of a particular implant. It rather tells you more of a conceptual ideas of how to do where to pick the osteotomy level and how long or what point of fixation you need. For example, a classification where you got to have a proximal and distal fixation must, or a proximal fixation and a distal fill. I can see Dr. Malhotra.
I think, Dr. Malhotra is probably of answering this question.
So Mojieb, that's a great point. And I totally agree with you that, what we have described, and Krishna has taken the lead in that, is to describe the morphological pattern of the proximal femur to decide how we are going to go about the osteotomy and putting the hip back. But the same thing can be done with a non-modular stem. The difference is that here in a modular stem, you are actually guaranteed a fixation in the proximal fragment through the sleeve, which may not be so with a non-modular stem because of the big mismatch between the proximal and the distal femur. And I think the same thing would just need an addition of plating or an additional fixation. But I think as far as the level of osteotomy or taking care of the aberrant anatomy is concerned, the principles will remain the same. The only thing which will differ is your fixation in the proximal fragment, which may need additional plating or some other, or strut if you like, if Mojieb is asking. I'm also a strut fan, but then I can't argue much with Takeshi himself. But then whatever method you use, but probably you will need to augment your fixation of the fragment in the proximal fragment.
Dr. Takeshi, your views on this?
Yeah, Well, that classification may be helpful because I use the SLOM for the CRO4 type.
Would any other faculty have an opinion before we do the closing remarks?
I said he has to make it universal for this to be applied universally rather than really limiting it to SROM only.
And I'll just interject as well. Actually, Professor Noor was nodding actually earlier when my critical comments about the modern cross-linked plastics. There are things coming across to the next generation of orthopedic surgeons. The classifications are typically based on North American models, and they are non-cemented. Now, I know cement is going out of fashion, even in India, which I'm sort of disappointed about, but of course, that's the trend in the world. The modularity and individualization, the ideal component is made with cement and steel in my book. That's how my teaching went. That's how my professional life went. But principally, don't forget that American classifications will only cover half of the technical market. They're only interested in non-cemented components. There are other things and other ways of doing it. And if anything I've learned this morning from all the conversations we have, we're all specialists. We're all actually experts in some, in our field, in the way we do things. Just keep that in mind. Classifications will pamper to a market. The Barrett classification for cementation doesn't ever fit into the writing picture of how you cement a hip. The Barrett classification is the American classification. The Vancouver classification about bone loss doesn't apply to me at all because I do bone grafting and it doesn't work that way. So classifications with a pinch of salt, You are experts. We have our own field, how we do fix and how we fix things. Just keep it that. Classifications are made potentially be a guide to communicate to somebody else what the problem is. But actually, in principle, how you solve the problem is your own technique and skill. Don't forget, we're all Stradivarius and Guarneris. Thank you.
Thank you, Bodo. Bodo's
Can I make one point? I think most of the patients are young, and you can do it with a solution stem or an Agner or a cemented stem. Whatever is the way you choose, you can do it with a subtrochanteric osteotomy. So I agree with Professor Bodo there. The point here is that if you are doing a surgery in a young patient, we must leave bridges open for a future surgery. So whether it be a cemented stem or with proximal fixation. So I'm particularly not a fan of distal fixation in young patients. So I think the way the dysplasia will go is with proximal fixation if you are using uncemented implants. So we don't want to do distal fixation. So that is why this classification, to understand that not all CRO4 are the same. We will not have a valgus neck shaft angle with a narrow canal in all the patients. We will have variations, and this variation can be associated with some sort of a change on the acetabulum. So for the younger surgeons who take up this case, they will look at it in a proper way and then make a plan, whatever is that plan may be. And the idea is to optimize the hip biomechanics with respect to the abductor function, at the same time not compromising on the subtrochanteric fixation part. So these two are the independent verticals which we need to take care. So you can do it with a cemented stem with an additional plate. You can do it with a distally fixing stem. You can do it with an SROM with an additional plate or no plate. So that is the individual choice based on their own training and philosophy. That's absolutely fine. But the classification per se can be extended to any particular implant design.
Krishna, I think you got the point. Proximal fixation, because of course you want to maintain bone. The problem we're looking at isn't a surface problem. Arthritis is a surface problem. It's just human inability to have a material to replace the surface that we need to go into the acetabulum, into the femur. Now, the acetabulum is the vulnerable bit of bone. There is not a huge amount of bone left. The femur, you can always extend right down to the knee joint. You're absolutely right. Maintaining the proximal femur was John Charney's goal. But he achieved that with cementation. He achieved that with load transfer through cement. And it's almost that challenge that you have to do. Fantastic approach. That's exactly John Charney's philosophy. Attack the proximal femur for load transfer. But the point for me actually is you're better off using cement because that's you're reducing less material and you get more uniform load transfer. It's about the uniformity of load transfer. You cannot achieve that with non-cemented components. They fix because they're wedging in. You get point loading. You're unloading the other bits. When I was a young surgeon, when I was your age, I studied that. I looked at percentages of bone ingrowth on non-cemented components. You need 20%, which means 80% of the bone is not loaded. Charney understood that 40 years before us, 50 years, 60 years before you, how to achieve. Well done. Good concept.
Thank you so much, gentlemen. And Bodo's pinch of salt taken in a pound with a pound of gold. So may I just pass on the dais to Professor Shahid Noor. Thank you very much. It's been a fascinating 3 hours of discussion, lots of questions, and thank you all for sparing our time. Dr. Shahid Noor, sir.
Thank you very much. It has been an enlightening session, a wonderful session, a galaxy of surgeons across the globe with different experience, from John Charnley, Roblesky to Bodo, and we have Mr. Tanveer Sadique on one end. And I want to personally thank each faculty, from Tahir Khan to Jim Sullivan. Vijay, excellent. We have worked together. Mojieb, good friend. Mansoor Khan and we work in the same city. And Gokhan from Turkey. Tanveer Sadique, I'm his student. I worked in UK under his training. So he's my teacher. And Takeshi from Japan, and Bodo, thank you very much. I mean, a lot of learning. And Krishna. So it has been an excellent session. There are faculty who spend their life, and thank you very much, Rajesh Malhotra Saab. I'm sorry. So there are faculty who spend their life in solving difficult problems. And to my young participants who are visualizing this session, and we're going to have this recorded and it's going to be available on the APHS website. First thing, we must understand what is a simple hip, what is complex, and what is challenge. It is the first thing. That these patients with dysplastic, they've already suffered. These are young patients. They've already had a difficult life. And first thing, we must understand that this is complex and this is beyond my experience. And you should have courage to discuss with your colleague faculty, and you should have courage to refer these to specialist people. We started with general orthopedic, and then we had orthopedic subspecialty. No, these are super subspecialty inside arthroplasty. That this is an arthroplasty surgeon with experience in dysplastic hip, or Mojieb is here, vast experience in sickle cell disease and AVN and preservation surgery. But now with this material available, and Tanveer Sadique showing a different classification covering the deformity of the femur, and Krishna, you have come up with different classification, and Vijay very clearly showing a Crow 4, and then subdividing into supratrochanteric stiffness and intratrochanteric stiffness. So it had been a wonderful session, great learning experience. Thank you again. In 6 weeks' time, we are going to have another webinar. While we were having discussion, Mojieb had been giving me different suggestions of important topic that can be covered, and that will attract a lot of audience. So next webinar will be on Saturday, 25th of June. Thank you very much. And lastly, I would request faculty who can contribute in helping Asia Pacific Hip Society in conducting cadaveric workshop. And also, I want each faculty that if they can pursue a fellowship program. So whether it be in India or England or Japan or Australia or New Zealand and Thailand and Indonesia, Malaysia and Pakistan, we want to create many opportunities for young surgeons. On top of that, we want to create visiting facility to somebody visiting Rajesh Malhotra Saab and Krishna and Bodo at Wrightington. So these will be short visitations for faculty who are already working but want to see, for example, a lot of faculty have not done SROM. go to Japan and see other people with vast experience of using SROM implant in difficult situation, Pro 4. So thank you very much. I conclude. This has been a wonderful 3 hours. Enjoyed every minute and second of it. Thank you very much. Assalamu alaikum.
Thank you.
Thank you so much.
Very much.
Thank you is also due to Meenakshi and Shrishti for their lovely and wonderful backup through the program. Thank you very much.
And also thank you to Jamal Ashraf, who had been a wonderful friend and technical, and it would not have been possible to conduct this technically without his support.
Thank you very much.
Bye.
Thank you for your time.
Thank you. Bye-bye.
Bye-bye.
Thank you, friends.
Bye-bye.
Thank you very much.
Thank you.
Wonderful morning. Thank you. Bye now.
Thank you.
Bye.
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 Tanveer bhai, shukriya. Tahir, shukriya. Abhay, good work done.
Yeah, good work done. Actually, I got scared. There weren't too many questions, so we had to create a lot of questions through the program. But I think acha ho gaya, sir. Because the one difference is that certain surgeons are doing phenomenal work in one area, so unka experience bilkul alag rehta hai, sir. There are lots of others in the same mix who would have done a lot more work.
There are more than one way that you can deal with the problem.
Bilkul, sir.
And I think for somebody who's in the middle of the career, he does not need to change his philosophy and experience and jump into another board. If he thinks that he cannot solve the problem with the experience that he has got, refer the patient to somebody younger surgeon who's experienced and is fellowship trained rather than. But Tanveer Sadique, I've worked with him. He just follow one principle. Very few implant that he used, but I think it has been a wonderful. Thank you very much. You've been a great moderator.
Thank you so much, sir.
Questions that you've asked and encouraged faculty to answer. So let's see.
Thank you so much, sir. So, Dr. Jamal sir ke thoda sa hum log will push him to get us into a cadaveric program as well, and we'll finalize in the next 3-4 days on the cemented hips. Okay. And registry wala apna webinar ko thoda work up karke we'll take 2-3 weeks and make a very good program, and uska faculty bhi thoda अच्छे से arrange करके market भी better करेंगे, sir, because that is something which nobody does routinely. Chaliye, sir. Thank you so much. Thank you.
Okay.
Bye, sir.
Bye.
Am I audible, sir?
Yeah, Meenakshi, please tell me.
Yeah, thank you very much, sir.
Thank you so much, Meenakshi, and thank you so much, Ritika, for all the backup support. Thank you, OrthoTV. Thank you.
Thank you, sir. Yeah, welcome. Thank you for joining, sir. Shrutika, you can end the meeting. Hello? Shrutika, you can end the meeting. Yeah. Bye.